Morning and welcome to the 24th meeting in 2012 of the Health and Sport Committee. As usual, can I remind anyone present that who has a mobile phone or a BlackBerry, I would request that those be switched off, as they can often interfere with the sound system. Agenda item number 1 this morning is we need to take a decision to take business in private, and that I propose, as we have previously agreed, that items number 3 and 4 are taken in private. Item number 3 is consideration of the approach to the scrutiny of Scottish Government's draft budget 2013-14, and item 4 is consideration of the committee's work programme. Can I have the committee's agreement? Thank you. Agenda item number 2 is access to new medicines, and we now move to our round table session on that access to new medicines. And members will recall that we agreed to hold this session to help our understanding of how new medicines are approved for the use in NHS Scotland, and that the systems of individual patient treatment requests are also considered. Although this is clearly a matter for wider public interest, the committee's involvement in it was originally brought about through consideration of 3 petitions. Petition number 1398, petition 1399 and petition 1401. And this session is intended to allow the committee to gain a fuller understanding of the way the processes currently work. The committee is discussing its work programme later today and next week, and during that discussion, or those discussions, members can and will consider whether the committee should carry out any further work on this topic. Can I ask now that both MSPs and the witnesses introduce themselves around the table before we go to our first question by Richard Simpson. Richard Lyle, could you start for us, please?
Thank you, Convener. Richard Lyle, MSP for Central Region of Scotland.
David, Director of Pharmacy, NHS Grampian.
Thank you.
Lee, MSP for Edinburgh Southern.
Dr Rachel Green, NHS GG&C.
Drew Smith, Member for Glasgow.
David Webb, Professor of Therapeutics at the University of Edinburgh.
Gil Patterson, MSP for Clydebank and Mulgai.
Jonathan Fox, Chair of the SMC New Drugs Committee and one of the Vice Chairs of SMC.
Bob Doris, MSP for Glasgow and Deputy Convener of the Committee.
Angela Timoney, Chair of the Scottish Medicines Consortium.
Duncan McNeill, Convener of the Committee and MSP for Greenock and Inverclyde.
Frances MacDonald, one of the industry representatives on SMC and Chair of the SMC User Group Forum.
George Adam, Paisleys, MSP.
Sandra Auld, Operations Director with ABPI.
Richard Simpson, MSP Mid-Scotland and Fife.
Andy Parry-Smith, Director at ABPI.
Annette Milne, MSP for North East Scotland.
Melinda Cuthbert, the lead pharmacist for Lothian Medicines Information Service and Yellow Card Centre Scotland, which is the Adverse Drug Reaction Centre for Scotland.
Thank you. We'll now move to our first question. It'll be a bit of a challenge to allow people to get in. There's a large number of us, but it's the MSP's clear intent that we, if possible, have that discussion across our witnesses, and we'll try our very best to do more listening this morning than talking. But first word to an MSP, Richard Simpson.
Me, except for the first question. I hope I don't talk too much, but this is a topic which considerably interests me. Since the petitions were submitted to the Petitions Committee and action was taken at that time, the government have, through the CMO, introduced new guidelines on how the medicines should be treated once they've been approved by the Scottish Medicines Consortium. Now, of course, the discussion today, we may want to consider every aspect of the process from a new drug being licensed through to it becoming available to the patients. But I want to focus down on the area in which the process goes from the Scottish Medicines Consortium to the patient. In England, the NICE, as everyone here will be aware, once it's made a specific recommendation, the primary care trusts are supposed to provide that drug. I mean, I think the reality is probably slightly different from the instruction, but nevertheless, technically they're supposed to be available, and the current government is making a lot of noise about if a patient doesn't get those drugs, they want to know why. But in Scotland, it goes to 14 different area drug and therapeutic committees, and not only that, it may be then referred to a regional working group in the particular area of disease that this drug is licensed for. And indeed, I've now learnt that there is a new consensus meeting being run by Health Improvement Scotland. So we've got multiple layers of bureaucracy before the patient actually receives the medicines. The guidance states clearly that this should be achieved within 90 days, but there are escape clauses like loopholes, like there should be if you don't have a protocol, you can delay it. And if you look at the tables provided helpfully to us by the ABPI, and you look at the responses by different area drug and therapeutics committees, they are widely different. But I want to hone in on a particular drug, ticagrelor, or Brilic, which was approved in April 2011 and is still not available to our patients 1 year later. In the meantime, there have been some sort of approvals from the regional group in the West for specific aspects of acute coronary syndrome, and in the East for other aspects of acute coronary syndrome when the Scottish Medicines Consortium gave general approval to this drug. Now, the approval in the evidence submitted to the SMC, and I would be grateful if Professor Timoney would confirm this, the evidence given to the SMC was that this would save 200 lives a year. And therefore, one reaches the inevitable conclusion that the delays now of over a year or even 15 months in the approval of this drug because of the bureaucratic process has actually cost 200 Scots their lives. And I would like the people here to comment on whether we have a process in Scotland from the recommendations by the SMC through to the delivery to the patient which is fit for purpose.
A number of questions in there, and I think, Professor Timoney, there was at least one addressed directly to you. But I mean, I think the complex procedure, the layers of process, the delay, are issues obviously that we're all interested in, and I'll allow you to respond first, Professor.
Thank you very much. I think it's probably important to start from the beginning, which is when a drug gets a license for use in this country. Mostly the license is through the European Medicines Agency, and that license will look at quality, safety and efficacy of the product. And will basically do a sort of benefit versus risk assessment and determine if that product is, in a sense, sufficiently safe and sufficiently effective to use in the population in Scotland. But the regulatory authorities are specifically precluded from considering cost when they do that. So someone within the NHS needs to determine what additional benefit we get from this medicine in comparison to the medicines we currently use, and what we're paying for that additional benefit, i.e. is it value for money. And effectively, that's the bit that SMC do under health technology assessment. So we look at the products and we'll make a determination that these products are cost effective for NHS Scotland. And we expect area drug and therapeutics committees then to look at that range of cost-effective products and decide which ones they need to use in their formulary. And without going into specifics about ticagrelor, effectively the guidance that comes from Scottish Government says they have to make that product or its equivalent available. And there are other medicines that do the same thing within NHS Scotland, and boards have certainly made those choices. So they've had a range of cost-effective products, and that shows to me that the process is working.
Any other comments from the witnesses? It is a efficient, seamless process.
I would just answer from the ADTC perspective that SMC does that initial cost-effectiveness analysis provides us with the advice that historically we would have done ourselves. And SMC was set up on the basis of removing that duplication and also bringing together the expertise that we have across Scotland to best effect. So that has meant that in boards our roles have changed in the way we use our ADTC. So it's very much more about consideration with local clinicians as to where a new drug fits within the pathway of care locally, what other drugs are in use, and how the new drug that's come to market fits with the rest of the choices that they have. So in terms of the timing, I would, we have moved in April to that 90-day timescale from pre-publication, so 60 days post-publication. And I think from our perspective, we work very hard to achieve that, and in the absolute vast majority of cases do achieve it. I'm
just trying to... Sandra Auld, sorry.
I think whilst Brilique is one example, I suppose I'd like to speak more generically about some of the issues of access to new medicines, and as part of the written evidence that we submitted, part of that was a snapshot of as most up-to-date decisions that we could illustrate. So since the CMO guidance has come into being, and this evidence demonstrates that there still is quite marked variance within the boards of implementation of the guidance. What ABPI is suggesting is not, we're not asking for anything new here. Actually, what we're asking is that the CMO guidance is implemented within the spirit that was intended, and that protocols are put in place within that 90-day period, and that there will be instances when that doesn't happen, but we feel that should be the exception, maybe 5% of the time, for example, and absolutely not the rule, and it shouldn't be used as a loophole.
Nanette Millen.
I noticed from the ABPI submission that you speak about the hurdles as they're described as actually generally lacking transparency and clear processes. Would you like to comment further on that, please?
Maybe in particular, that comment was directed around, in particular, the consensus meetings, and I'd maybe hand over to my colleague Frances.
Sure. We had a comment on the consensus meetings that have occurred so far. While we can understand the logic of trying to come to a Scottish view in terms of how a product is used, we had a concern that the consensus meetings it's unclear exactly where they fit at the moment. They just seem to give another hurdle on the pathway because they're not giving clinical guidance. They make a clinical statement on the use of the product without actually doing a thorough clinical review, and it appears that the health boards still have to do their own protocol development. So they're coming in more as a hurdle than necessarily a help. And the transparency is they don't appear to have a thorough clinical review, but they make a clinical statement.
Do you wish to respond to that? Yes.
I'm only aware of one true consensus meeting, and that was Dabigatran. So I think we should make it the singular rather than depicting it as a common state of affairs. And I think if you look back, and hindsight's always good in 2020, but it was absolutely the right thing to do. There were introducing Dabigatran was complex clinically in terms of prioritising patients and working out who would best benefit. In managing the entry of that in terms of changing clinical practice, some of the initial, if you like, not murmurs, but issues around concerns, maybe around making sure that we targeted patients who would get the best benefit and not get harm from that drug. And to some extent, that's been borne out. You know, there are safety concerns around Dabigatran. Use in Scotland hasn't, grown certainly as much as we'd first anticipated. And I think that is that it is one of a group of drugs that are coming. There is a natural caution in terms of adoption of a new treatment, particularly one in this area. And I think the usefulness of a consensus statement around dabigatran was there. I don't see it as being a step which has been introduced permanently or across the board or for other medicines. It was brought together for that one. And to that extent was useful.
I think
you wish to respond to that? Yeah.
Some of the lack of clarity, you're quite right, there is one, but some of the lack of clarity is why that specific disease area, because most products that come have the same question over long-term safety and efficacy because they're assessed in trials that have a certain limited duration. So I think that's one of the questions. And how valuable they were to the health boards is therefore unclear to us as well, simply because it didn't appear to make the decision-making faster in terms of adopting or not adopting the product thereafter.
Convener, I'd just like to clarify a point that was touched on by Professor Timoney and also by Mr. Flegger in relation to the respective roles of the regulatory body, the Scottish Medicines Consortium, and which of course is a consortia of area drug and therapeutic committees, and then the area drug and therapeutic committees themselves. Professor Timoney talked about the role of the regulator in assessing safety and efficacy. So one of the issues that I have as a constituency member, having received correspondence from constituents, is that there appears to be evidence that a medicine is not being made available. That is to say, the area drug and therapeutic committee is not putting it onto their local formulary on the basis that there are safety concerns with regard to that medicine. I'm just wondering whether the experts around the table think that that is an appropriate rationale for refusing to place a medicine on formulary and for not making that medicine available to the patient. I can absolutely understand the rationale that there are alternative treatments available, which is often the explanation for why a medicine that has been approved by SMC is not placed on the formulary. But I do think there needs to be some real clarity around the issue of safety and efficacy, because if that issue has been dealt with by the regulatory body, why is it then being used as a reason for not placing medicines on formulary and not making medicines available to patients?
Yeah.
I mean, I guess it would be useful to have some specific examples, but our committee would not take an assessment of the safety of the medicine. They would be interested in the safety of using that medicine and maybe some of the issues that go with its use. But no assessment of safety. That's part of the licensing process, and that's accepted. And I wouldn't recognise that as a response of our ADTC in terms of saying why we wouldn't use a medicine.
Just remind us which ADTC?
Grampian.
Grampian. I know that this is meant to be an informal discussion. It's just that's a helpful clarification. But are you saying that in your experience of how this operates in Grampian, you would not fail to place a medicine on formulary simply on the grounds of concerns around safety? And there are no examples of where that has happened?
Right, let's be
Obviously,
very...
I'm thinking about my own experience as an MSP in NHS Lothian.
Yeah, let's be very clear here. I think in general, I agree with what you've just said as a summary of what I've just communicated. I think what we need to be clear about is that there are discussions at formulary groups about the benefit versus safety profile. That's different to saying we wouldn't use it because of safety. So you might have a drug which gives you more benefit, less risk. And that would be better than a drug that gave you less benefit, more risks. Those discussions are legitimate, absolutely legitimate. But no, I wouldn't recognise, and if there has been, I'd be very interested to know, a situation where we would say, no, we're not going to use a drug on safety grounds because that's been licensed. Because that is that assessment of safety. That is one of the prime purposes of the licensing process.
You know, again, referring to, as my colleague did, to as a layperson and representing constituents, they can't understand, and maybe we can get to some of that the various layers take place. You've got the European licensing, you've got NICE, you've got the SMC, then you've got the boards, so it becomes another hurdle. people see the support, get the support of their consultant for that appropriate medicine. They see it being issued in England, Scotland and Wales, and they think, this is a massive bureaucracy that's applied to my medicine, which I believe is vital to my quality of life, that I'm being prevented. There's no other area in the health service that's subjected to this sort of scrutiny and outcome in terms of, is this good value, is, you know, we don't do that with any other procedure in the health service. My constituents say to me, and I'm subjected to this bureaucracy. And then when we get success, it goes in the health board system for sometimes 6 months or a year. Now, is anybody, you know, today prepared to defend that system around this table? No, I think people are hiding behind for my constituent, it is a whole system. For the people round here, it's different parts of a system, and we can all justify our part of it. But the cumulative effect on that person who wants the medicine is pretty drastic. Yeah, Professor Webb.
So I have been involved in SMC in the past, and I think the SMC system is timely, robust, and covers all medicines. So in some ways it has advantages over the NICE process in England. And it provides, I believe, very good decisions that help health boards do their work. The fact that it does it for all the health boards, I think, is a very helpful process. What perhaps hasn't been captured in the discussion so far is that SMC will approve all drugs that are cost effective. That doesn't mean they are cheaper than what's come before. They may be more expensive than what's come before, and they may offer no major additional benefit. And so there is another piece of work that has to be done to decide whether the benefit provided or the additional cost makes that drug worthwhile for use in Scotland. So it's knowing that a drug is cost effective is good. Knowing whether it's the best option for patients is a separate issue.
All procedures carried out in the health service are all cost effective. Why is that
No,
higher? Why I'm asked, is there a higher test for medicines than any other procedure in the health service?
Perhaps one could argue that level of scrutiny should occur for surgical operations, for other medical practices, for nursing care, for homeopathy. There are a lot of things we do that perhaps could be brought under scrutiny. I think it should be widened, not narrowed.
Andy Powrish-Smith.
Can I just ask Professor Webb to clarify
yes,
something?
I'll let you get back, but, you know,
all right.
Andy Powrish-Smith.
Thank you, Convener. I'd echo some of the things that you're saying. I think it is easy to be drawn into individual sections of the system and the rationale behind them. But if we look at the overall picture, the UK is, I think, 11th in Europe in access and uptake of new medicines. And within the UK, then, we see huge variability between devolved nations and England. And then within Scotland, we see huge variability across boards. And I think from a patient perspective, that's very hard to justify. So whatever the individual rationale behind different parts of the system, ultimately the whole system is making access in Scotland low and slow for patients.
Yes, sir. Timony.
Hi. I think I tried to describe what we do in the context of the whole system, because I think you're right. We shouldn't be looking at individual parts of the system. It's important to remember we spend £1.3 billion a year in NHS Scotland on medicines, and we would be failing in our duty to the public and to patients if there was not appropriate scrutiny of that expenditure. And what we do at SMC is just one part of that, looking at new medicines. But our hope is that by testing the cost effectiveness at that early stage and being able to advise clinicians and prescribers about what's best use of a medicine, that will help in terms of treatment access. Andy's perspective about low and slow, I think, is a really interesting soundbite, but the reality is there's a recognition that our prescribers in Scotland is a very cohesive clinical community, and they are perhaps in some ways conservative in their use of medicines. That's not necessarily a bad thing. When new medicines come to market, there are still issues about safety and efficacy and risk. What the licensing authority says is effectively this medicine is safe enough to try in the population. not that it is generally safe. And so I think that measure of clinical conservatism and the advice that we can provide helps good practice.
Do you really believe that you know, that all of these stages need to be as rigorous, as all of these stages are absolutely necessary in the process? That you have put all of that work in the SMC, and we can have a board that can embark on another year's piece of work on work that you've already completed. Why is that necessary? I mean, it's, as a layperson, I'm asking you that question. Why is all of that necessary?
So I sit on the TASED ADTC. So at TASED ADTC, we do not go over what SMC do. We don't even look at that. We accept the SMC's assessment. But then, if SMC have said that a particular drug for blood pressure is cost effective, even in that same chemical entity, that same therapeutic class, there could be 7 medicines. Well, it would be inappropriate to put all of those 7 medicines on. That's not the most appropriate way to guide practice. However, what's really important is not about whether it's gone on the formulary, it's about whether, if SMC have said yes, can our clinicians in TASED get access to it? Yes, they can. And they can get access to it whilst we go through the formulary processes. And that actually gives us some cohesion in terms of the systems and processes that we use. And then there's a cohesion between primary care and secondary care, and we're working as one community.
Bob Doris?
Yeah. I just wanted to clarify a few things, because there seems to be 2 separate parts of the process. I would like information on the time it takes SMC to approve or not approve new medicines compared to, say, NICE, for example, because that part of the system I think we have to get on the public record about how timious or otherwise that is. But secondly, I think where Richard Simpson's concern wasn't actually part of that. It was after that process how the ADTCs do their jobs. Now, part of my concerns with that was partially ameliorated by the fact that in the case Richard Simpson gave, there were other equivalent drugs that could have the same effect that were being prescribed. So in terms of loss of life, there would be no evidence of that because there were other equivalents that could be used. But I think the concern is, irrespective of, and if you could just clarify this bit as well, how GPs and other clinicians can prescribe before an ADTC puts it on the formulary, what the process around that, to give us some reassurances over that. But isn't, at the very least, it's unsatisfactory how the health boards give this information to the public and how they account for it? That seems, a lot of the uncertainty could be relieved if there was more consistency in how health boards reported this information. So 3 questions in there. I hope that's helpful.
Yes.
Okay, so I've taken it that you're asking, first of all, about timelines. The second question is really about GPs and other prescribers once SMC have given advice. And the third thing is about information to the public.
Yeah.
So in terms of timelines, basically SMC is a rapid health technology assessment system. Our entire process takes 18 weeks, which is one of the most rapid systems across the world and is recognised as such. Publication in BMJ Online in January of this year compared SMC timelines to that of NICE and basically concluded that SMC provides their guidance within a median of 7.4 months of marketing authorisation, and NICE it's 21.4 months. So again, evidence is available to Scotland at an early stage. That's timelines. In terms of GP prescribers may prescribe whatever medicines they feel are effective and useful for their patients. And we would encourage them to look to the SMC guidance in terms of making that decision. They're not precluded from doing that prescribing. They don't have to wait for it to go on the health board formulary to prescribe for their patients.
So can I just, so they don't, this is separate from individual patient treatment requests or any of that? They can directly prescribe?
Yeah.
Okay, right.
And then the fine thing is about information to the public, and actually I would agree with you on that point. I think probably this is not very well communicated to the public. I think the most recent guidance that came out from the Scottish Government in February of this year said that health boards have to make their information available on websites within 14 days, and that had to be enacted by the 1st of April. And I think this committee may wish to check that that's actually happening, because I think that possibly hasn't been as good as it could be in the past.
That's helpful. Thank you, Convener.
David Peffler, Layer.
I'll just come in there as to offer the board perspective around that. I would agree with the last comment around the communication. I think we got the guidance in February to enact end of February to enact by April. The priority was around providing access within that timescale. And whilst the communication of that access is extremely, extremely important, I think I would be the first to admit that we prioritise the access bit. Make sure the patients can get access when they're speaking to their consultants, their clinicians. And I would agree that, certainly from my board, we recognise we've got more to do around the communication of those decisions to make sure that it's clear for patients. So I would also just comment that we are 6 months in since the guidance. So we're probably at the point, certainly where locally, we're reviewing that, how are we adhering? So we've been working to make sure the guidance is implemented. And it's that natural point, 6 months down the line, where we're working to see how are we adhering to that. So I think, yes, we would welcome an extra push around that, but I think let's also recognise that it's that sort of natural timeline that boards were beginning to say, how are we doing against this? Are we doing as well as we should be? Are we doing as well as we could do?
Anyone else? Melinda Cuthbert.
Just from NHS Lothian's perspective, we've always had a website where it's freely available, not just to the healthcare professionals, but to patients as well. Within that website, we do publish our decisions on medicines, whether or not they've been added to the list of medicines which are prescribable. But in saying that, even if we make the decision that we have a like-for-like medicine already in use and we do not wish to use another medicine, it doesn't preclude any prescriber from requesting that medicine for their patient if they truly think there would be additional benefit from their patient receiving it, and that's via a non-formulary process. So even if the SMC say yes to a medicine and locally we decide that it's not the one that's preferred, it doesn't stop anyone from actually prescribing that medicine if they can actually find that there's a niche for the patient to receive it. And with regard to the new guidance on implementation within 90 days, that is currently being tracked very closely by our formulary pharmacists and our medicines management team. And from the information that we have from 1st of April to present is that we are achieving that 90-day decision period. There was a couple of those which have been delayed for protocol, and one of those, for instance, is one of the newer antibiotics which has just come out. And the reason for that is, as you are aware, antibiotics, the development of those are becoming less and less. So when we actually do get them, we are concerned about resistance. So we want to make sure before we do initiate it that we actually have protocols in place within our antibiotic alert policies to allow them to be used appropriately.
Drew Smith, I see Jim Eady and Dr Simpson and Sandra all wanting in, so we're getting warmed up, thankfully. And Richard, I see him waving. Drew Smith.
Thank you. Just briefly, I mean, on the issue of communicating the decision, I'm not entirely clear necessarily how that helps. I mean, if there's there are issues of principle here. People are, if I or a relative of mine believed that a particular medication was likely to extend your life, improve the quality of your life, and someone in a different part of the country, on grounds as far as that person is concerned by postcode, is able to access that medicine, but you are not, and the only explanation really that you're being given is this particular health board doesn't want to spend the money on it, how does improving the communication process in all of this help that individual?
Sorry, I'm just struggling to see how we've jumped from Melinda's comments to that situation that's just been described. But, so if SMC has said yes, I truly don't see an issue of access. I think there are, we've had the comment about there are occasions when a protocol and the local guidance and getting the clinicians to decide how they're going to use a drug takes slightly longer than the 90 days. I think the requirement for us to implement within 90 days is challenging at times, but is correct, and we work to achieve that. I don't recognise a situation where we would say no to an SMC drug that's got a yes on the basis of simply cost or affordability. I don't recognise that situation.
Sandra Auld.
I think it is clear from the evidence that we've gathered recently, and I reiterate some of what I said earlier, that there still is wide variance amongst the boards of the interpretation and implementation of the CMO guidance. As of this month, 5 boards in Scotland, there is no information available about the formulary decisions of new medicines, and you know that's fact. And I think to relate to Mr. Smith's comment about communication, I think from a patient perspective, to be able to find out what medicines are, you know, if the medicine you need, is it available, and how might you be able to access it. I think that is important. And then the transparency of the processes within health boards, I think also are important. And I think to have 14 different processes throughout Scotland, and to pick up on the convener's point, I think that is a system that is difficult for patients to understand and to come to terms with.
Andy Powrie-Smith.
Yeah, I think it's great that we're hearing examples of such good practice around this table, and it's probably looking at the wider picture. So, you know, and just analysing one medicine that went through SMC and what the decisions have been and what's happened in the 90 days and so on since that, you know, we see 5 have not been included on the formulary because they're waiting a protocol. We see 5 where in 5 boards, in another 5 boards there's no information available. In 3 boards, no decision published, and in 1 board, it's not been included. So, to some extent, any examples of what happens locally and so on around this table is probably less relevant than the wider picture of actually this is the reality of what's going on. There also just seems to be an assumption that prescribing something that's not on formulary is an easy process for a GP to go through, and I'm not sure that that's necessarily the case. So it's maybe slightly anecdotal, but we have experiences shared with us from clinicians that there is a certain administrative burden attached to prescribing something which isn't on the formulary, or when you go down to the drop box on your electronic prescribing system, then the medicine isn't there yet because it hasn't been added to formulary, so you need to go away and find it elsewhere. So I think we just need to be careful that just because SMC have said yes, we don't all sit around the table and assume it's fixed, because we would certainly contend from an industry perspective that the timious nature of SMC processes, we absolutely agree with the pace and speed that SMC make their decisions. We are really supportive of. It's what happens then that when the issue kicks in.
Jim Eadie's anxious to make a point on this theme, and then I'll call on David Peffliger.
Yeah, I think it's really helpful to have the range of views that we've had so far in this discussion. That go back to something that Professor Timoney said earlier, which is that it's absolutely right that the level of medicines spend in Scotland, which is over $1 billion, should be subject to the level of scrutiny that it is, and I accept that. But we've now had 3 statements from Professor Timoney, Mr. Flager and Ms. Cuthbert around the fact that if SMC says yes to a medicine and it is not placed on the local ADTC's formulary, then there are no barriers to patients receiving that medicine. And all I would say is that as somebody whose interest is that of representing the people who sent me here, my constituents, I have written to my own health board, NHS Lothian, and been told that a medicine is not available because it has not been placed on the formulary. And so I'm genuinely struggling to understand how patients can access medicines that SMC have approved but that are not on the local formulary. And if you're able to provide further reassurance on that, either today or in writing, that would be very helpful for the MSPs who are having to represent their constituents and who are writing regularly to their local NHS board asking why the medicine that has been SMC approved is not being made available to their constituent.
David.
Several comments. First one is around the ABPI data, which we have to accept that's a snapshot. I think my response is the one I made a few minutes ago, which is communication versus access. And I think what the ABPI presents shows that we're not achieving those aspirations, well, not the aspirations, the requirements of the CMO letter in terms of that communication. I think it would be interesting to see the access data behind that. So I think, and it's absolutely right that we expect the SAL17 CMO guidance to be in place and adhered to. Next comment was about formulary and SMC yeses, which may not be on the formulary. Formulary is largely about peer review and peer consensus about how medicines are going to be used locally. So if you have a request, if a prescriber wants to use something that's not on the formulary, that is, in essence, not in line with the peer view. So I think, whilst you said that there are no barriers, I think I would say that we would never get to the point where we'd say no, but I think that, that there has already been a view locally from clinicians that as a group, they collectively wish to use a particular treatment over that other treatment, and they will have reasons why. And so there needs to be discussion with the clinician as to why those reasons maybe don't apply. And I think that would be those would be the two main comments.
Bob, you wanted just to pick up on something there, and then I'll...
Just very briefly, because I know others are wanting in. Right, okay, if Ms Reedy has had a reply saying that it's not available, a drug's not available because it's not on the formula yet, but GPs can still prescribe it, then the important thing for me would be that what information is given to clinicians post-SMC approval to know that if they make a judgment that that's best for their patients, that they can go ahead and prescribe that. I accept that the formula might be about a strategy for rolling out a specific medicine across the health board area for replacing other drugs and for what particular conditions it's most appropriate for. I understand that protocol can take some time, but what information goes direct to clinicians at the earliest stage after SMC approval so they can make that judgment call irrespective of what the health board at the centre is saying? That would be quite useful to know.
Professor Timmy?
Yeah, I'm happy to answer it from an NHS Tayside perspective. So effectively, the general practitioner's terms and conditions require him to make medicines, to provide the medicines that a patient needs. And so if those medicines are licensed, then he's entitled to do that. So a formulary is not a list of drugs, and those are the only ones you can get access to. Most people, most boards would have a process where they'd say, we would like to see 85% or 90% formulary compliance. We accept that maybe 10% of medicines will not be on the formulary, and all clinicians know that. There's a different process in primary care than secondary care, where in secondary care, effectively, the consultants and clinicians in hospital, the medicines have to be stocked in the hospital pharmacy. So effectively, there will be a non-formulary process, and they will all be familiar with the fact that to fill in the non-formulary request form and so the medicine can be ordered in for them. It's a standard process that's been in existence for some time.
But can you help me there? Because I don't know all of this, but I've had people, constituents, who had consultant support for a particular medicine who couldn't get access to it. And you're suggesting to me this morning, if the GP had prescribed that, it'd be okay. Is that the message?
Is this an SMC approved medicine that your constituents wish to have?
So, but it's an SMC approved medicine, because I think this is part of the language and the insider language that confuses people. There's a need, as I understand it now, if the SMC approve it, but it's not on the formulae of the health board, then the GPs can prescribe it. But
if the GPs then will be monitored in terms of their formulary compliance.
And how regular and common is it that they would prescribe off of that?
So basically, in terms of our local compliance rates, our GPs are incredibly compliant with our local formulary, and it's probably 1 or 2% more than our hospital prescribers, to be honest. So mostly they will look to that local formulary to give them guidance around what they use.
What's coming over to me, that it may be an issue of communication, but this insider jargon, this insider knowledge and everything, it's all completely familiar to you. It's excluding people right across the board from an understanding, a simple understanding they have about getting access to a medicine that might improve the quality of their life. And I don't see anybody around the table so far actually taking that into account. Andy Powrie-Smith.
Just pick up on something David said there, that the actual data around access and the uptake of these medicines would be very interesting to look at. And I wonder whether we're slightly kind of missing that element, because that's really, if we want to understand whether or not we are driving new medicines through to patients that need it, then having the data, I suppose, in the public domain around what health boards are using and what levels would be useful for us to then make decisions on.
Richard Lyle.
Yes, Chairman, I've listened intently, and can I say I agree with the point you've made, and I especially agree with the point that Jim Eady's made. Can I throw a grenade into the ring and ask on costs? And can I read some facts into the record, if you bear with me? Discovery, research, development and clinical trials of a medicine takes an average of over a decade and costs over £1 billion. This is from the submission from the Association of British Pharmaceutical Industry. Figures show that the price of medicines in the UK is amongst the lowest in Europe. Some people may disagree with that, and I would like the panel's interest in that. But I think the most interesting from the submission is prescribing volumes have increased from 69.5 million items in 2002-03 to 94.6 million items in 2011-12. So that's nearly up a third. NHS ISD states that this growth reflects not only the availability of new or more effective medicines, but also increasingly patient expectation, demographic changes, and latterly the implementation of clinical guidelines and recommendations. But I think the other statement they're making is very interesting. Meeting the increased demand for patients for medicines is costing the NHS Scotland progressively less in real terms given. Do the panel witnesses agree with that? And why is it, the question I'm concentrating on the same as you have, why is it if SMC have passed something, why are other boards looking at it? Why are they not passing it and passing it on to the people that we represent who want it? We are being told that the system is working, so why isn't it not working? Why are we dispensing more medicines but not dispensing the medicines to people that say they're not getting it? I, like others, got over 100 emails over the weekend, in particular to one case. Why is it that people who need medicines are not getting them? I would like to know that answer.
Anyone want to pick some of that up? Oh, Melinda Cuthbert, thank you.
Sorry, I'm having a blank moment here now at reflection.
Why are people not getting the medicines they require? Because the costs have been shown to go down, so we're being told. The money is there, and the SMC have passed it. So why are clinicians not dispensing it?
Right, okay, I suppose there's a couple of things there. For one, a newer medicine isn't always a better medicine. We might already currently have something within the system that is equally effective. The other thing with new medicines, as Professor Webb has already alluded to, and Angela, is that when a new medicine comes out, we do not have the full safety profile. And any medicine, it's a process of risk versus benefit to give it to the patient. Some medicines have greater risk than others, and some have less. But when you start putting patient factors in there with their other medicines that they're on, the other disease states they have, then that introduces a further risk. Sometimes patients that we actually end up giving those medicines to post-trials are not patients that were exposed to some of those. They may have been excluded from other medicines that were included in there. They may not have been in there because they had decreased kidney function or decreased liver function. So when we start giving those out there in the actual environment, there is additional risk that we need to consider. Now, if we have medicines already on formulary that are known and trusted and we have confidence in them, we are not going to automatically jump to a newer medicine just because it's new. We have to then look to see, are there any additional benefit that would come from prescribing that for patients? So if we already have a medicine that's doing that, then if there's no additional benefit to switch, then health boards may make the decision that they will not give that as the preferred medicine. But as I'd already said previously, if a clinician does make a case that their patient may have additional benefit from it without the risk, then they are able to get it. Coming back to the issues about access, when a medicine comes in, I think that if it's approved by the SMC, then it's different from the not approved by the SMC. And Mr. Eater, I'm not quite sure about the circumstances that you were...
SMC approved medicine.
Okay. I think that it's probably inappropriate for us to pick up a specific case here, but if you want to discuss it out with the meeting, I'm more than happy to do that. I don't know what went there. Did the clinicians support it, or was there other issues that took place? But without going into specific details, which wouldn't be appropriate without the patient's permission to discuss that here, I don't think that we probably should pick that up here. But
the example on, and sorry, just no, I have to clarify, convener. I gave the example on an anonymised basis. I haven't chosen to.
No, you haven't mentioned that, and then there'll be an opportunity, obviously, after the committee, and we'll try and resist getting into individual constituency cases. Dr. McDonald.
Just picking up on that point, maybe it's worth clarifying a few points as well. The SMC is different from NICE, as was said, and the industry is supportive of the SMC role. And of course, it reviews every medicine, so it's a different situation from NICE. However, in reviewing it and also in having an EMA licence, it's already assessed that the benefit-risk ratio is acceptable. And in the SMC review, it's clear that the product is cost-effective. So I think to say that the products may not be sort of valuable in themselves or may not be any better. If they're not any better, they have to be cheaper, otherwise they won't get through, and that's rarely the case. So in most cases, they're at least equivalent and they do bring some value. However, I take your point that you can't put every single medicine on the list because, of course, you might have another range of alternatives. However, I think the issue is that every single medicine that comes will have a limited safety profile, and that's just the fact, and that can't be a factor for not putting it in a protocol, because otherwise no medicines would be picked up. However, the need is to put them within a protocol that puts them in context of the other options that you have. And I think the big need for the patients is to get those decisions on the protocols made as rapidly as possible and in a rational manner, and then basically put that medicine in place where it's going to bring most value. And I think that the frustration is that the development of those protocols and the placement of those medicines where they're going to bring most value is too slow. And I think one also has to remember from the safety point of view that the local regulatory body, so the MHRA here, will be monitoring the safety very carefully. And therefore, there's a very rapid turnaround and making sure that the patients are not getting unnecessary risk. But it's back to the safety issue. The safety should not be a reason not to put it on the list. We need quick decisions on protocols.
Any of the other witnesses? No? Professor Webb?
I mean, I agree in essence with what you say, but it's really important to recognise that new drugs are generally more expensive. And when they offer an absolutely equivalent benefit, then you may also look at the relative safety of those two drugs. So I think that's quite important. And maybe going back to Dabigatran, one of the issues that's emerged is it's a blood-thinning drug. It's useful for heart attacks, strokes, blood clots, just like warfarin. We hate to have to use warfarin. It's a very complicated drug. It's difficult to individualise treatment, but you can terminate the effect when someone has a bleed. The newer drugs, it's very difficult to terminate bleeding. So there are safety issues you have to bear in mind. Now, it's too detailed to go into that too far, but safety does come into play when everything else is equal and the price is much higher.
In many cases, that's not the issue. You're quite right. If two products are exactly the same and one's more expensive, then probably it wouldn't be seen as cost effective. But you know, there are factors. There might be reasons why you don't want that medicine at this point. But I think the frustration on the industry side and some of the patients is the decision with regard to where that product fits and what subgroup might get most value is a protracted decision, and it's often variable by health boards, and there's a lack of clarity as to, and to some extent Dabigatran's an example, there are probably some high-risk patients that would benefit from that product, but the consensus statement is a very blanket, it's last in therapy, and it's almost too simplistic. There is a need to have a broad discussion and a transparent discussion and a decision, and then everybody can see what the factors are, and there's some equality in place.
I think I agree with you on that point. I mean, I think there is room for more clarity, perhaps more speed and more consistency and more transparency. That I don't disagree with.
That word consistency is the one that really interests me, because we've got 14 different area drug and therapeutic committees, and we've got evidence that they come to their decisions at different speeds and in different ways. And okay, if it's, if it's exact equivalence, as Dr. MacDonald was saying, I can fully understand you don't. I mean, I was a chair of a pharmaceutical liaison committee, probably the first in Scotland back in 1980, and we had 35 different iron products, and we were trying to get clinicians to agree that we should only need 4 or 5. And I tell you, that took 2.5 years just on iron products, for heaven's sake. So clinicians, are eccentric. They do need a degree of management. I accept that fully. But what my constituents are saying to me is, if I live in Tayside, I get one drug, and if I live in Forth Valley, I get another drug, and my doctor tells me he would like to prescribe the drug that my colleague gets in Tayside, but he can't effectively because it's so bureaucratic and difficult, and he'll be under such pressure that there's no point in him pursuing it. Now, if we get to a situation where the drug is available, and I was mentioning Brilique because that really interests me, that one, because the West has decided that it should be available for certain things, and the Lothian has decided it should be available for other things. And yet SMC said it should be, that they gave general approval, not restricted approval, general approval. So the consistency we have across Scotland is, if you have your heart attack in the West, and it's a particular type of heart attack, you'll get this new drug. If it's in the East, you won't, or vice versa, because the thing is just, from my constituents' point of view, it's confusing. It really is confusing. So the consistency that Professor Webb referred to is something that seems to me to be lacking in the system. And there's no monitoring centrally of this. There's no monitoring of the timing. There's no recourse if the ADCCs don't actually pick this up within 90 days. They don't have to report to anyone centrally at the moment. And so that's not monitored. So the consistency is not monitored. The timing is not monitored. We have a system that is deeply flawed, in my view, at that level, not the SMC level.
You want to respond, Mr. Playfair?
Yeah, I have no arguments about the application of Self-17 or the CMO letter. There must-dos. If we haven't done it, we need to hold up our hands, say we haven't done it, and get it right. And I think that's where my comments around the communication come earlier. I just want to clarify two issues. One is around formulary. What we've heard this morning is very much SMC down to formulary, ADTCs in boards. What that doesn't recognise is that those formulary processes are generally open. So there can be an application for any drug, any indication, normally licensed. Some ADTCs will look at others. But that process is open. So for the situation where you have a prescriber who wants to prescribe what's in Tayside, there is a route for them to get that on the formulary and get the peer support, peer review, to have that clinically available, generally supported by the board on the formulary. The other thing was about GP prescribing, because I think there's a danger that the committee will go away with slightly the wrong impression. You've got an SMC that is a yes, and we've decided one of the ADTC functions is to agree which clinicians are going to use that drug, which clinicians are going to be the responsible ones to use that drug. And there are many of the SMC drugs that are hospital-focused, and for a lot of those cases, it would be wrong for a GP to prescribe it. It would be out with their expertise. They wouldn't have the support to do it, and therefore it wouldn't be appropriate for them to use that drug. Angela is absolutely right in saying that the contractual arrangements for general medical services mean that we can't restrict what the GP can prescribe. But that's slightly different to the professional and clinical consensus that's gained in the development of a formulary. And that's why formulary compliance is so high, because they're the agreed drugs that the clinicians themselves have agreed. Let's remember, ADTCs are full of clinicians have agreed they're the ones that should be used.
Richard?
Yeah. Can I come back on the point Melinda Cuthbert made earlier? And it's getting across to me, is a clinician frightened to take on board new drugs because, I've got my old drugs in that cupboard, I've used them for 20 years, great, I'm not going to use the new stuff. What's coming across to me, Chair, as a layperson, is if the SMC pass a drug, it should be throughout Scotland that every board or a clinician should be able to use it if they so wish, if in consultation with their patient. It's the patient that counts, not the layers above that. It's the person who is possibly want to live, wants to extend their life for a number of years or whatever. I've given facts which show that we are giving out more drugs in this country than ever before at a lower cost, and we are doing the best for the people of Scotland. What is coming across to me as a layperson is we are not grasping what we should be. The new drugs that are there that clinicians should be given to their patients if they so require. Yes, the old drugs are good, but maybe they're past their sell-by date. Now let's move on and look at what we can do better for the people of Scotland. Do people agree with that?
Oh, Dr. Green.
I wonder if, as a clinician, I could just say a few points. I think there is certainly a comfort in drugs that you have used for many years, and you know the safety profile in a variety of different clinical situations. When there is a new drug, if it is SMC approved, and you believe that that is beneficial for your individual patient in front of you, then you prescribe it through a non-formulary application. It does require filling in a form, but it is not laborious. This is not difficult to do, and it happens all the time within a hospital. The differences between those that are SMC approved and those that aren't. I think the committee need to recognise that if SMC approves it, it can be used if there is a clinical advantage to the patient, and that is between the doctor and the patient. So that was really just...
Dr. Fox.
Yeah, well, as well as being involved with the SMC, I'm mainly a clinical consultant in a kidney unit. And I can say quite honestly in my clinical practice that I believe that an element of conservatism in this, with a small c, I hasten to add, in the use of medicines is entirely appropriate and in line with the best traditions of British medicine. I don't think the idea that we automatically use new medicines is appropriate or correct. And I'm talking about people in my own family, if I were to treat myself, I would prefer, in the first instance, to use medicines with a long track record of benefit and a low risk of harm. I just wanted to make one other point while I'm speaking, which is to do with the introduction of medicine, the comparison of Scotland with other countries in the world. Just bear in mind, many other countries in the world don't actually have effective systems for assessment of medicines. And in fact, Scotland is the envy of some of those countries, and some of them are coming to us for advice on how to introduce such systems, because it's entirely appropriate to assess cost-effectiveness of medicines. There's only one cake of healthcare. We can't, it is appropriate to assess the value of money of new medicines and to decide what we might not be able to afford if we spend too much on them. Thank you.
Sandra Auld.
Just on that point, on page 3 of the written evidence that we submitted, there's a graph which is from data supplied by the Office of Health Economics, which demonstrates that the uptake of new medicines in Scotland as compared to England, Wales and Northern Ireland is lower over a period of up to 4 years from launch.
Dr. Fox, you
agree with that interpretation. I mean, this is the graph we're talking about, and if we're applying a scientific method to the analysis of graphs, you'd say that certainly the three of Scotland, Wales and Northern Ireland are effectively identical. And whether or not they differ significantly from England is another matter. As I say, that would be a scientific analysis of that graph. The other thing is we've already discussed issues about what uptake means in this context, and I don't think we should go through those discussions again.
Professor Webb.
Well, first of all, I'd like to reassure Mr. Lyle that clinicians do want to give the best treatments to their patients. We absolutely want to have access to those best medicines. And in my field of medicine, which is cardiovascular medicine, I feel Scotland has allowed me to access medicines sooner than in other countries. And our system is an envy throughout the world. I think it is a very good system, and we get early access to those medicines that bring important new benefits. Now, just examples from some time ago, imatinib and Herceptin were launched extremely fast in Scotland after they were approved by MHRA. So our patients with cancer got very early access to very important and radical new treatments.
So, we've got the best system in the world, and all those people out there are complaining about nothing. And and is that the message from those who are deeply involved in the system for reviewing and giving access to medicines? The system is perfect. It can't be improved, and those people out there, particularly in orphan medicines and cancers, are being hysterical. Dr. Fox.
I think we've already heard some suggestions for improvement in terms of monitoring the response to this, CEL, which states that decisions should be made in 90 days and communicated. And I think that's an area where a clear area, a way we could move forward is making sure that given an appropriate timescale, because I think it's too soon to take a snapshot of that, but in an appropriate timescale, that is appropriately monitored and enacted.
Anyone? Nanette Millen.
Sorry, I found the whole discussion extremely interesting. But can I ask perhaps people around the table to elaborate a bit more about the assessment of the orphan drugs, or drugs prescribed for or developed for very, very rare diseases, certain rare cancers and so on? Because there seems to be doubt being raised that perhaps the health technology assessment should be modified in terms of drugs like that. Now, I'm no expert in this sort of thing, although I have an ancient medical background. But I would be interested to hear a bit more from the experts in the field about what currently should be done, and should, as ABPI suggest, there be a short life working group set up by SMC from boards, from ABPI, academia and patients to examine ways of approaching HTA for these drugs.
Okay, and Frances perhaps can speak to it as well, because she's used to be involved with a drug company that produced orphan medicines. So orphan medicines are given that designation by the European Medicines Agency. So it's a sort of separate part of the regulatory process. And that new system came into place probably about 2001. There's lots and lots of orphan medicines in development at the present time. And the reason for that regulatory system was effectively to try to encourage drug companies to produce medicines for rare diseases where it might not be commercially of interest to them to do so. So in the European Union, basically, that the rules are that it's kind of less than 5 in 10,000 people are affected by the disorder, and it's of a serious nature. And in doing so, what the companies get back from that to some extent is they get market exclusivity for 10 years, and if it's for a paediatric medicine, I think it's another 2 years in addition to that. So they get an additional time to recoup their costs of development. They also get support to get through the regulatory system, so that effectively they get a lot of meetings and the fees are reduced, so that it's easier for them to get their drug to market to some extent. So that's what, and an orphan medicine from an SMC perspective is one that's been given an orphan medicine designation by the European Medicines Agency. When we look at it then, because it's been supported to get through the regulatory system, the reality is that the clinical trials programme will be smaller than it is for other medicines. So the evidence base is not as robust. Normally, the nature of the clinical trials may be slightly different as well. So we'll be dealing with a lot more uncertainty about what are the benefits of this medicine. And SMC are very explicit that we accept that uncertainty. This is a medicine that's got a licence. If it's an orphan medicine, we accept uncertainty in the case and some weaknesses in the case associated with that. And then the committee are used to dealing with orphan medicines. We've looked at over 75 orphan medicines since the new designation came in, and we say yes to over 60% of those medicines. And effectively, when it comes to SMC itself, we basically then have to consider Are there reasons why we might want to say yes to this drug, despite the uncertainty in the case? And we are comfortable to do so. And we may also sometimes say there are reasons why we would accept a higher cost threshold to say yes to it. So that's the process we use. What's been suggested from some of the submissions in terms of rare diseases is that they say that we're so different that you can't do that. I don't see any evidence of that to some extent. And I think what I'm hearing when I read the submissions that come through, in general, people are very supportive of the SMC process, but everybody says, but our drug or our disease or our treatment area is different, and so you should do it for everybody else, but not for us. And you as a committee need to decide, was there a sufficiently strong reason or is there evidence that our processes cannot look at that in that comprehensive way? And we at SMC feel that the application of our modifiers allows us to say yes in these difficulties where we don't have as much clinical evidence as for other medicines. And we hope that patients in Scotland, as a result, get access to cost-effective medicines. The issue, I think, to some extent is, though, that not only is there less of an evidence base around orphan medicines, but sometimes there's quite a price premium attached to that. And therefore, the value for money case it's more difficult to prove that. That's up to the companies. They have to decide what they think the market will bear in terms of the cost.
Dr. MacDonald.
I fully agree with the summary that Angela has given on the SMC and orphan medicines. But I think there is a discussion that could be had on the topic. If you take orphans, there are a lot of orphan medicines because the epidemiology says 500 per million patients. So there are a lot of medicines now which are targeted in orphan. So maybe it's easier, first of all, to look at the particularly rare diseases that sometimes are called the ultra-orphans, where there are maybe in Scotland 10, 20, not very many. And sometimes the term is used for England, for example, uses the break-off of less than 500 patients in England. From the drug development perspective, those medicines will still cost an appreciable amount of money to develop. And the fact is that every drug that comes to market has to accept the sort of weight of the medicines that didn't make it through development. So it's not just paying for itself, but it's paying for those that didn't make it. So I think the fact is there will be some medicines for rare diseases where the cost effectiveness, accepting that the SMC does accept more variability, the cost effectiveness just cannot make it within the accepted criteria of cost effective, which is often this 20 or 30,000 pounds per QALY. And if the company is going to want to invest, or if any company is going to invest in these areas, then they cannot make the price the same as a statin. So there will be a price premium simply because of the recovery costs. And I think that's where there is almost the need for a societal discussion of what does the society want to pay for, because it is impossible for those drugs to come in at a very low price. And some other areas, such as NICE, for example, England has looked at this area. They put it under the hat of AGNIS, which is an advisory group and specialised commissioning. They've now put that over to NICE. But they've basically said, let's see if we can evaluate them in a slightly different manner. We will look at cost effectiveness, but we will also look at the extent of unmet need, the severity of the disease, the societal impact of the disease, the societal benefit of treating these patients. For example, they might be in paediatrics where there are carers looking after them. So they don't have the answer as yet, but they have said, we think there's a case here to be opened up and discussed, because if you don't, then those products, so the ultra-orphans, to use that term, are highly unlikely to get through a conventional HCA assessment. And I think that's probably also the case, in a Scottish context. Very few of those products can get through, not through any fault of SMC, but just because they are high price, and that's a fact.
I just think, Convener, listening to this, one of the things that I think Richard Lyle was talking about, it was kind of, I suspect, motivated to talk about people being restricted from drugs because of the 100 or so emails we've had in the run-up to this committee about an individual patient, and the expression postcode lottery sometimes used. I think we very helpfully got a briefing ahead of this committee about drugs, medicines for orphan conditions that are available in England but not available in Scotland, but actually are available in Scotland and not available in England. And it's all about the clinical evidence that you used. For example, and apologies for pronunciation if I get this wrong, imatinib is a medicine for an orphan condition, gastrointestinal tumours, which is available in Scotland but was turned down in England. Not a criticism of the English system. They do due process for the the systems they put in place. What I'm keen to look at to scratch with the surface, convener, rather than comparing that kind of thing, which I don't think is actually helpful to progressing the situation, is to look at the modifiers in place with the SMC, not just for orphan conditions, but end of life and other factors that are taken into account, and ask the witnesses at the table how they would modify the modifiers, if you understand, how you would enhance the modifiers to make it more reflective. Have we got the balance right on those modifiers? Could we go further? And those are the comments I would be interested in. One final thing, convener, with your indulgence. I know Sandra Auld, sorry, it was Dr MacDonald that spoke about the societal benefits. My apologies, I can't remember. Sorry, Dr MacDonald mentioned that. I'm more interested how we can build into the SMC process, if you like, value-based pricing towards it. So when we look at a threshold of £20,000 or £30,000 or £40,000 for the quality, depending on the modifiers used, I would like to know about the on benefits to, say, local authorities are, in terms of if you're prescribing that new medicine, what they will save. Because where we are just now is we're looking at integration of health and social care, and I think this is something we have to look at in some great detail. So in general terms, the modifiers, do we have to do more? But where does that sit in terms of that integration of health and social care and getting those modifiers right to start to map out the benefits, the economic benefits to using these new medicines?
Dr MacDonald.
I think that's why, or I know that's why we made the suggestion there ought to be a short life working group that actually discuss this, because I think the questions are clearer than the answers. You're right that in some disease areas, if you consider the societal costs, then there will be some savings there. But every new medicine is not going to save money, I have to say. But the question is, if you know, what is the boundary that you look within in terms of seeing where the costs and the benefits are? And the suggestion is that why should the societal benefit, for example, on care provision at home, not be considered when you consider the days in hospital as well? There's still costs to the system. So the suggestion on our side is that one has a discussion of what society wants and what the benefits to society are and what the costs are, and widen that discussion in certain circumstances.
Webb? No. I'll let you in next.
So we're talking about health and it's important to recognise that if you're going to have that discussion, it needs to be broader than just medicines, because sometimes we're talking about rare diseases with very expensive medicines with marginal benefits, and that money might be better spent in other ways. Better carer support, home changes in the home so they can get into a bath more easily. It's not just medicines. There are other things you can do to improve patients' lives.
I agree with what Professor Webb has said. You wanted to talk about the modifiers and wanted to hear from the committee in a sense. I think what would be really important, because we don't actually know in Scotland what the public would wish us to do, and I think it would be worthwhile, and I think this committee could recommend that we need to actually research public attitudes. So I actually don't think we can set up a short life working group, because to some extent that will be a talking shop of people's views and opinions about what people in Scotland want. I think it would be really helpful for us, not just at SMC, but for NHS as a whole, to understand what patients would value and what the public would like us to spend our money on, and to research public attitudes, and that would be a very helpful contribution. Because the issue about rarity at the present time, the evidence around that is confused, but mostly suggests that the public don't value rarity. If you have a severe disease and you can treat that disease with a medicine and you can get benefit from that medicine, then you should have the capacity to benefit whether you've got a common severe disease or a rare severe disease. And it's not clear that we would wish to value rarity on its own, and I think that's an important point, but we need to get a perspective from people in Scotland around that.
But would you not need to extend that to all the provisions of the health service?
Sorry, and
what
that's
we
why
spend
I said,
at end of life
yeah,
is a significant amount of money that's costing probably the health service a darn sight more than what some of these medicines would cost. I mean, I think that's part of the grievance, and part of the communication is that people who come to me and say, I can't get this medicine drug that would radically transform my life because of cost, is confirmed sometimes by the SMC. Because when the drug company comes along and says, well, you've got a bargain now, we've reduced the cost, it triggers the consideration. It triggers access to that by reducing costs, not by making it any safer, not by doing anything other than reducing costs. And the SMC tells us, you know, one of their major jobs is to reduce the costs, and they're very proud about keeping the cost of medicines down. So is it any wonder that people say this is not about safety, or nobody cares about it, this is about cost?
Okay.
Professor Webb.
I'd like to open up one issue, which is the thing called opportunity cost. So in the health service, you've got a limited pot, and we're in a recession now where we're not going to get much growth in that pot. You've got to spend that money giving the best value for every pound you spend. And the reason why things change when drug costs come down is because when the cost comes down, the value goes up. You can then spend that money. If you spent that money while the cost was high, you'd be not spending it on things that were better value for money. That's what it comes down to in the end.
The SNP consulted, the SMC consulted when we introduced a policy of free prescription charging. Is that the does anyone want to comment on that? If that's the best use and best cost-effective way of providing medicines? I'll ask the witnesses a question. I'll let you come back, Richard.
I think the Health and Sport Committee or the Health Committee at that stage, when they were considering free prescription charges, had an evidence session, and SMC were present at that evidence session, is my recollection.
I make the point, just that when we're talking about costs, we're denying people, what they believe is life-saving, life-changing medicines, and they're judged scientifically and cost-benefit and whatever. You can't argue with that process. But they say, why only me? Mr. Powrie-Smith.
Touch on what Professor Webb said there. I think there is an opportunity cost around all spending in healthcare, and the Medicines Bill accounts for 12% of overall spending. It went up 2%. Last year, which is obviously less than inflation. And when we're making these decisions, I'd say the Medicines Bill comes under a different level of scrutiny than any other kind of healthcare intervention. And actually, we perhaps need to have the debate around all of our healthcare spending and what we get the most patient outcomes for. What can we deliver the most for patients in Scotland for every pound we spend? At the moment, it feels very difficult to have that conversation because it's SMC is the rigorous process around cost efficacy, and we don't apply that in other areas. So when patients or companies come to make the case for a new medicine, it is a different level of hurdle, investment, etc., to get that in, as opposed to other areas of healthcare spending.
Professor Webb made a very useful observation about opportunity cost, and he gave the example earlier of dabigatran. There are also cost savings for introducing what might be a high-cost medicine. And I think the example that you gave is one where you can actually save NHS funding through the reduction in the use of warfarin clinics, for example. But I think the substantive point is that if you were to listen to part of this discussion, you might think that there's no funding available for orphan medicines or ultra-orphan medicines. And clearly, while this is a difficult area, there has been funding made available for those treatments. And I'm interested in the distinction between high-cost medicine for an orphan condition or an ultra-orphan condition, which might have a low budget impact because of the small number of patients across the country. And I know that there are arrangements in place north and south of the border. There was a reference made to Agnes south of the border, and there's a system in Scotland for considering how we pay for orphan medicines and ultra-orphan medicines. And I'm interested in the views of the panel about the distinction between high cost for a medicine and the budget impact that will have on the health service generally, but also the system that we use for assessing whether those medicines should be funded north and south of the border. So should the system in England be learning from Scotland, where we have a less formalised system, although it could be argued that is not as open and as transparent, or should we be looking to adopt the system south of the border? I'd be interested, given the experience of the experts around the table, to gain their understanding and views on that subject.
Mr. Timothy or Dr. Fox?
So effectively, in Scotland, there is a system for under the National Services Division where they have a process in place for medicines that have gone through SMC. And this is particularly for rare orphan medicines where it may be due to patients may have a kind of a genetic component to their illness. So it may be that in one health board there are 3 patients who have that. So it may unequally fall across the health boards. So they have a risk-sharing scheme among the health boards which is administered by NSD. The process is that where the medicine has to go through SMC, if SMC have said yes, then it will go to the chief execs as a group and they will decide whether or not to put it on the risk-sharing scheme, and money will be taken from the health boards into the risk-sharing scheme and effectively used to fund that medicine. And so it means that that's a kind of a fair system across Scotland, and it's one where they've agreed to share the risk among the chief executives. I think that's quite a good system. We've talked already about Agnes in England, and I think we need to say that the Agnes, which is the system that they developed in England to try and look at orphan medicines, has struggled and has not been able to give any advice to date on orphan medicines. And they're now going to be incorporated within NICE, and so I look to see how NICE will develop that system. I have to say that Agnes worked very closely and looked at our systems and processes, and we helped them quite a lot in developing theirs, and we wish them luck in the future in developing a process that works.
As against the high cost of an orphan or ultra-orphan medicine.
Dr. Fox.
Now, I was just going to say, in addition to what Angela said, that budget impact is not, although we ask for information from the companies about estimated budget impact, it does not have a role in the SMC's decision. So whether it's low or high is not a matter for the SMC.
Representative of SMC?
Well, I'm actually very much in favour, as you might imagine, of the whole cost-effectiveness, value-for-money argument. I'm also well aware of opportunity cost. And I do agree with Angela that one thing we must find out is how the public values various interventions and various kinds of condition and the treatment of them. And I think that is lacking. And you've said, why should medicines be subject to this kind of scrutiny? Well, I would accept that many other interventions should also be subject to the same scrutiny.
Dr. MacDonald. I've got Richard Lyle and then Richard Simpson.
Just to continue that discussion, I agree that Agnes don't, and ultimately Agnes taken over by NICE, do not yet have the answers as to how to assess these ultra-rare diseases. But I think one advancement is that they've recognised that there is a need to consider looking at them differently and looking at a wider definition of what's value. So going beyond the slightly traditional cost per quality, and that would be one of the things that we would ask, is that relevant in a Scottish context to also consider widening that picture of what's valuable. I don't disagree that rarity per se is not just the issue. I agree with your point that it has to be severity, but there are many rare, severe diseases where there are some potential treatments, so I think they do need to consider differently. In terms of the budget impact, we appreciate the SMC does not take that into account, which I think makes sense considering that you judge everything. And I don't think industry would say just because it's one patient, it costs a lot, you should approve it. I think they still need to be evaluated within a systematic framework, and budget impact is just one factor on the side.
Professor Webb?
I just want to endorse that point. It's value for money that we're trying to get. Budget impact, for instance, if 5 years ago we'd had to treat everyone in Scotland with a statin because that would reduce heart attacks and strokes, probably Scottish Government couldn't afford that. So that's an affordability for government. If we think it's good value for money, we would recommend it.
Perhaps as a point of reassurance, so I've taken over as chair May last year. Since that time point, we approved dabigatran, which the company, the manufacturers themselves estimated was going to cost NHS Scotland £20 million in 5 years. We approved the treatments for hepatitis C, massive step forward. There were easy decisions for us. This was value for money, and we thought patients should get access to those treatments. And the companies estimated that was going to cost NHS Scotland £50 million. So our decision wasn't based on affordability. Can the NHS afford it? We made the decision based on what is best for patients. And I'm proud we've made those decisions. And actually those medicines are now used in Scotland. And in a rapid process to allow access to good treatments is what this is about for me.
But those who campaign for the prostate cancer drug, abiraterone, complained bitterly about the delays and the time it took them to go through that whole process. And, you know, I think, again, was this contrast about what was happening down south, and that was in place. And people who were in the terminal stages of the illness were denied that treatment while the negotiations went on to get a reduction in price. What price for those who were left in that situation? They took, you know, how long did it take to get through the process?
Abiraterone, the NICE decision came out a couple of months before us. As I've said, effectively, in 9 out of 10 cases, SMC give advice before NICE. So you could argue that people in England are generally waiting in a way that people in Scotland are not waiting. With regards to abiraterone, we looked at it in April and said no to it. And the drug company had to address the weaknesses and uncertainties in the case, and they had to look at some of those issues to make the product cost effective. And they were then able to do it. And I think that's a right and proper process.
What was the game changer? Did you get an insight about that discussion? The game changer was reducing the cost of that drug to the health service. It wasn't in and around its effectiveness, safety or anything. It was about reducing the cost. It was a cost negotiation that went on for months with terminally ill people at the heart of that decision. That's the way the campaigners saw it.
And I think that's right. And I think that's unfortunate because that's not how it was. First of all, I think we've looked back since our meeting with you at the end of August. I've looked back to see in how many cases when SMC have had a resubmission, has that resubmission gone through the process purely because of a difference in cost? There's been one cancer medicine and it was not abiraterone, and one set of eye drops. So apart from that, we've never had a resubmission from the companies, which is just about cutting the cost, because we don't engage in. It's really because they actually have to identify the population and provide us with certainties that actually the evidence will show benefit for that patient group.
The cost is at the heart of the quality, is it not?
It's part of it. It's about value for money. How well does this work against the cost we're expected to pay for it?
So, Bob?
Convener, I think it's clear we should state the obvious just for the public record. I've spoken to a lot of pharmaceutical companies through the summer and ahead of this meeting, and I've respected very much the evidence they've given, and they're clearly experts in their field, as are the clinicians from the SMC. But can we state the obvious and say that pharmaceutical companies would wish to get as high a price for their medicines as possible? That given, there is always going to be some form of negotiation. What I would like to know, and perhaps it can't be provided today, if for every medicine that the SMC approved on resubmission, where the price was lower, what would the differential be had we approved it at the first time of asking? How much more money would that have cost the Scottish taxpayer each year? Because effectively that's taking money away from frontline health services, and I think we have to get that into perspective, because we have to talk about the costs for everyone who's a patient in the NHS and where that money comes from and where that money is going. So each time that a pharmaceutical company resubmits at a lower cost with greater efficacy arguments as well, if that was accepted the first time of asking, I would like to know how much more money the drugs bill would be for the NHS in Scotland. I think that's important to get some perspective in this.
David Plavliga.
Picking up that point, I'd like to expand it somewhat, and I think it's about the transparency around the submissions from industry, actually, and it's picking up that point about what are the drivers that would make this cost-effective and acceptable to the NHS. And I think we lose that. When there's a no from SMC on the grounds of cost-effectiveness, it will often give the value of the QALY, also that it's not in the realms of acceptability in terms of cost-effectiveness. What I and the board would really like to know is what are the key drivers of that would make it cost-effective. So, to answer your question, is it the cost bit? Are they asking for too much money for the effect that they're going to get? In other words, the cost-effectiveness is too low, and they're asking us to pay too much for that level of effectiveness. Or is it that the drug isn't effective enough? Is it that we need to demonstrate that it is more effective than the evidence they have at the moment? And perhaps that just needs more evidence, longer evidence. So I think those drivers around how that quality is constructed, how the financial case is constructed, is something that we would definitely value access to. And where it would become particularly useful is around a subject that we haven't touched on this morning, is around IPTRs. Because it's understanding how then that general case for the population that industry is looking for that drug to be used in applies to that individual patient. And that is a piece of information that at board level is somewhat hard to get because you're restricted in what information you have available. So there is something about saying, how can we get access, better access, to some of that submission that goes to SMC? And that comes, I think that builds on that point completely, which is saying, well, you know, what are the reasons around that assessment of cost effectiveness?
Ultimate Donna.
Gosh, there's a whole range of comments that have come up in that mix. The price of medicines, I can't defend every company's pricing policy, but I would just say that I don't think companies are trying to charge, you know, absolutely the highest, but you're quite right, they have to get the return back on their investment on that product and the products that didn't get through. And quite often I've heard comments around the SMC table saying, okay, sometimes that's a high number, but sometimes that's a very reasonable number. So I think you can't paint them all as just being sort of extreme at that top end. And of course, once the product goes off patent, then you get the flip side and you get them at a very reasonable price. In terms of what stops the product getting a yes, sometimes it is because the cost per quality is high. Sometimes it's because, and I'll come back to that in a second, sometimes it's because there's uncertainty around the clinical data and it's not the cost per quality. And I think you can actually see that in the DAD. I think it's reasonably clear to judge what it is because sometimes it says the economic case isn't made, sometimes it says more in the clinical case. Not that the drug isn't safe and effective, because the EMEA said that, but when you link the endpoint to the economic benefits of the endpoint, sometimes the uncertainty is the issue. One factor we haven't touched on that sometimes makes the cost per QALY more difficult, if you remember, the QALY is mortality, so how long do you live extra, and what's the quality of that life you live. It can be very hard in some cases to get that quality bit, the quality of life, to put in your trial an instrument that's sensitive, that can be measured between 0 and 1, which is ultimately what goes into the QALY. So you might find your patient, particularly with chronic diseases, they might walk a little bit better, they may, with Alzheimer's, for example, function a little bit better, but to find an instrument that actually will allow you to measure that sensitively and can be converted back into this 0 to 1 scale is actually quite difficult. So you can often have a hard time showing the quality of life benefit, but you still have the cost. And that's also the case where if it's Alzheimer's, for example, you can't count in the social costs. So all your benefits have to go into a rating between 0 and 1. You're not increasing their lifespan in Alzheimer's. So you've got the 0 to 1 factor, which is the only thing that you can hook your benefit onto, but you've got all the costs. So I would say personally that there's, which was also in the industry application, that there is something to be done to look at the QALY in some disease areas where it's a chronic disease. But these things all add to the uncertainty and can add to a number which might be too high or a degree of uncertainty which just isn't acceptable. Does that answer your question a bit? I think the DAD explains it well, reasonably well, and if it doesn't, that's maybe something for discussion for the SMC. I think it's reasonably clear, but maybe that's because I read them a lot.
Sorry, if I can just come back. I mean, I think the DAD is useful. What I'm suggesting is that that there is room to draw additional information from the case that's put by industry to SMC and draw that either through to the DAD or preferably in an open way so that patient groups can see it as well, but at least to allow boards to have access, particularly around those individual patient treatment requests where we really are trying to, would benefit from a little bit more additional data, I feel.
What the DAD is? I believe it's something called a detailed advice document.
The DAD stands for Detailed Advice Document, and that's an 8 to 10 page document that comes out from SMC that provides advice, not just about cost effectiveness, but about the clinical advantages and disadvantages of the product.
Sorry, I apologise, but can I just add that that's not just from me. That request formally has come from the group of ADTCs in the northeast of Scotland when we were discussing sharing best practice around IPTRs. So it's not just one board's view. There are other boards that have that view as well, and that information would be useful.
That number is ever collected in terms of if where the initial price that a pharmaceutical company asks for a medicine to be approved at is refused for not just in cost, but the cost effectiveness thing, the quality. I get all that, and I fully accept that. But if they then come back with a lower price in that formula, there's then technically, if the SMC have said, yes, that's fantastic, let's go for that initially, if they hadn't have done, there'll be a cost saving. Is anyone counting those numbers? Because we've got a situation just now where we've got a political judgment to make as committee members, where the convener said about we could have just said, yes, let's approve abiraterone, for example, but you can't just pick out abiraterone, you have to be consistent with every pharmaceutical intervention. What I want to know is what the cost saving has been to the Scottish taxpayer, separate from the wider social and medical benefits, what the cost savings be to the Scottish taxpayer to get that lower price, because we have to put that in some kind of context. Is anyone collecting those numbers?
Frances, do you want to speak first about?
I think that's a very rare situation. Whether anybody's counting numbers, I'm afraid I can't answer, but the industry, don't see the SMC as a price negotiating forum, and it's a very rare, out of the 700 odd applications the SMC has done, that's a very rare situation. The company generally puts in a price which is influenced by their global pricing policy, and more recently there are patient access schemes which have influenced that, but there is very, very little bartering back and forth, and we wouldn't see that as the way we wish to use the SMC, and it's certainly not a strategy that companies would adopt.
I think just for clarity there, I wasn't suggesting there's bartering. In fact, the SMC has been pretty consistent saying it's not a price negotiation, it's a cost effectiveness based on the quality with modifiers. I'm just saying, as a politician looking at the numbers, because we've got our budget process coming up as well, a politician looking at the numbers where it goes in at price X, no negotiations in terms of the price, but price X from a global pricing strategy goes in. If it's not recommended and then it comes back at price Y, and price Y is lower than price X, surely someone should be counting those numbers.
It is also
the SMC, perhaps.
So the point is Frances has referred to patient access schemes. Patient access schemes are part of the UK reserved pricing system for medicines. And effectively, the patient access schemes allow medicines which may not be considered to be cost-effective to become cost-effective because of a discount in the price. I can tell you the figures in terms of the medicines that have gone through patient access schemes. So effectively, since it was brought into place in May 2009, 44 schemes have been assessed by the Patient Access Scheme Advisory Group. 27 of those are what we call simple schemes, so it's just a simple discount. 17 of them were complex schemes, which may have actually either complex financial or clinical issues associated with them. Of those 44 medicines, 36 of them were accepted by the Patient Access Scheme Group as feasible for implementation in NHS Scotland. Of those 36 medicines that the Patient Access Scheme Group looked at, they all came to SMC. SMC approved 20 of them. And so 15 of them were simple schemes and 5 were complex schemes. But those prices and those discounts are confidential under the reserved UK matters, and so we haven't looked at the cost. But you can assume that those systems will have brought additional benefits in terms of costs.
I won't pry any further, Convener. It's just Convener was making the point about had we just said yes at the outset for certain drugs and the benefits that would have had for patients. And what I'm trying to scratch the surface of is what would be the budget consequences of just saying yes at the outset each time. I think that's important to know when we're looking at a health budget.
Richard's been very patient with me.
I'd like to turn back to two comments I made earlier. As far as I'm concerned, free prescriptions has been an excellent idea, one which has shown, and with the figures I gave earlier, which has, I think, benefited many of the people in this country. Well, just a comment. Also, Angela Timoney, Professor, sorry, Angela Timoney, made a comment. What would the public like? The public would like the best health service in the world, access to all the drugs that they require, and a better expectation of life. But can I again return to what I thought was an excellent presentation by the British pharmaceutical industry, and they make a recommendation, and I'd be interested in people's view on this, which is quite, again, a good comment. They want the Scottish Parliament to examine the best use of the estimated £316 million worth of savings which will be made in the cost of medicines to NHS between 2012-15, with a view to identifying what proportion can be and should be reinvested in meeting patients' expectations of access to the latest medicines. And in case I don't get back in, I have to say it. What I have seen this morning, as far as I am concerned, is that we are frightened to access these new medicines. And that when the SMC passes them, it should be the end of story. It should be then the clinicians who should then be able to access the medicines which they want for their individual patient, wherever they are in this country of Scotland. We should have the best health service in the world. And I think we do have the best health service in the world. I think you all do a good job, but sometimes we should get the ribbon, the red ribbon, and cut through it, because sometimes we're containing too much clutter, which we should get rid of. Thanks, Chair.
Yes.
Just to respond to that, just quickly, and I don't know if I can be of help. You'll have seen from the ABPI submission that effectively we are spending more money in medicines now than we were previously. So that £316 million, basically, which has come from drugs going off patent, is being used to treat other patients with the other medicines that are available, particularly generics. So effectively, for branded medicines, they have a patent life, they have exclusivity, they can make their money on that. Once that stops, it becomes a generic medicine. Effectively, as the population gets older in this country, they get more and more medicines. And so effectively what we're seeing in terms of the increase in the drugs bill is mostly to do with increase in volume, because more people are living longer and getting more medicines. And that's what's happening to that money, and that's a good thing.
We're starting to run out of time. We've got a couple of other issues, and I think someone mentioned it earlier in terms of the individual, the patient treatment request and stuff like that. I think, you know, you're due in, Richard, but I mean, I think we need to get that on the record. I don't want to preempt your question, but there was some other stuff in the evidence that we had in regards to the you know, give people an opportunity to rebut or whatever this about the clinical research needs access to new medicines. The implication was, well, Jim, will you take that one, that question, and I'll take.
You want to take clinical research first?
Well, I was going to let Richard in because he was waiting, and let you do the clinical research question.
I mean, I think, Chair, I entirely agree we should be moving on to IPTR. Just two small points to clarification. One was about the horizon scanning that SMC does for the boards, because it seems to me that if that is effective, then in fact protocols and preparation for the budget costs should actually be well in place before it gets to the point of the actual approval. And it's just understanding the timeline on that would be helpful. And the other area is, it's been made very clear to us that one of the reasons why it doesn't go on to the formularies locally, apart from equivalence, is the innate conservatism of the system and the protection that affords patients, because it's not always wise to rush into new medicines. But is the MRHA system of monitoring medicines post-approval, post it going out and being used in the general population, as opposed to the very selected trial population, is that system working adequately? I know it's a UK system, but if, from a Scottish point of view, are you comfortable that the SMC-approved drugs that are then being used are being properly and effectively monitored, so that we can actually see whether in reality, before we get value-based pricing, whether they actually deliver the outcomes that are there with the safety that it was originally there in the licensing process? Sorry, they're quite long questions, but they're quite specific, Chair.
Professor Timoney.
I'll answer the horizon scanning one and perhaps turn to some of my colleagues, Professor Webb, perhaps to talk about the pharmacovigilance issue, if that's okay. In terms of horizon scanning, SMC work very closely with the pharmaceutical industry to identify what drugs are in their pipeline. And effectively, we send that out to boards so that they give advance notice and can prepare. But what you need to know is effectively, at that stage, the drugs even haven't been through the licensing process. So we can't guarantee they're even going to get through the licensing process. They may get through the licensing process and not get through the SMC process and so forth. So in terms of boards doing that work, they keep a watching brief on that. But it would be inappropriate for them to start preparing all the protocols because it's about 35 to 40% of medicines actually get through. So it would be a lot of work that's not really necessary to some extent. So that explains what we're trying to do, but it's trying to make sure we've got the plans in place. But it all gets refined as it goes through each step of the system, really.
Thank you.
Professor Webb?
So, MHRA acts on behalf of the UK to undertake pharmacovigilance and support safety. They work very closely with the European agency, and I believe they do a very good job. I don't think there's any problem with the analysis of safety. I think that's very robust. There might have been something implicit in your question about real-world effectiveness as well as safety, and I think that's not quite so well addressed. And there isn't a body that takes that on in quite the same way as the further refinement of safety. And we really have to often rely on clinicians and the NHS itself supporting research to look at real-world effectiveness once rather more complicated patients are getting the drugs than they were in the original trials. So often that sort of information does come through, but it takes a number of years.
Unique data linkage system, the CHI as well, but the capacity for Scotland to actually be a leader in that field, if we were getting this right, we could actually provide a very useful service.
I think it would and should, but if we're not careful, the English system, CPRD, will soon
overtake
have the
us.
same capacity.
That's why I raised it. Yeah. So it leads into the research issue, actually.
Am I coming in at this stage?
Just a sec, I don't know where, Melinda, do you want to comment on this?
David's already covered the MHRA perspective, but the yellow card scheme, which is what we have, that's the MHRA does on behalf of the whole of the UK, was one of the first spontaneous reporting systems that was established in the world for monitoring adverse effects of medicines. The major problem with spontaneous reporting is under-reporting, but that isn't unique to the UK, that's an international issue. And one of the remits of Yellow Card Centre Scotland is actually promoting the Yellow Card scheme and to provide or try to facilitate education and training for healthcare professionals to increase the reporting profile. But obviously other things inform the MHRA's safety as well with regard to clinical trials and post-marketing evaluation.
On that. Jim, Edie?
Thank you, Convener. I think there's acceptance that Scotland has particular strengths in clinical research and clinical trials, and I know that there's expertise around the table. I'm thinking particularly of Professor Webb and the work that he's been associated with at the University of Edinburgh. The issue, though, is that some of our leading cancer clinicians and researchers have written an open letter to Scotland on Sunday, one of Scotland's national newspapers, highlighting a number of concerns that they have, and it may well be related to what they perceive to be the effectiveness or lack of the individual patient treatment request process in relation to cancer patients. But they have highlighted a number of issues, one of which is that the ambition of the Scottish Life Sciences Strategy, and I speak as the convener of the cross-party group in the Parliament on life sciences, has an aspiration to double the economic contribution made by the life sciences industry by 2020. So they highlight that and suggest that the operation of the various systems in Scotland may impact on our ability to reach that objective. And what they say specifically is that because of the lack of availability of cancer medicines, and I'm paraphrasing, they say, and I quote, "Due to Scotland in many situations no longer treating patients with the standard of care used in other parts of the world, Scotland may not be able to take the lead or take part in global clinical research studies, National Clinical Research Network clinical trials, or many other commercial trials which require the standard therapy in such trials to be what is approved by the regulators, but which is increasingly not the standard of care in Scotland." And they go on to refer to a number of adverse effects that would flow from that. which would undermine Scotland's strengths in basic science and translational medicine. Now, the individuals, Professor David Cameron, Professor Jeff Evans and Dr Marianne Nicholson, who I believe was once a member of the SMC, are individuals who will be known to members of the panel. And this is a very serious challenge to the NHS and to the Scottish Government. I think it's one that this committee needs to put on the record, and I'd be very interested to know whether panel members share the concerns that have been expressed and what their view would be.
Anyone wishing to respond to? Professor Timoney.
Just very briefly, first of all, I think what I want to say to Mr Reedy is SMC would share your concerns if we thought that there was challenges.
Sorry, Professor Timoney, I'm just putting on the record the concerns that have been expressed by the cancer clinicians. They may or may not be my own concerns.
Thank you. Well, thank you for that clarification. Basically, we would be concerned if we thought that Scotland was not able to participate in clinical trials, because we think that's really important for our patients as well as for our clinical research and clinical practice. At SMC, we have only had one instance where experts have said to us that a medicine we'd already said no to it, it had come back as a resubmission, and the experts said to us it's now becoming standard of care and it will be important from a clinical trial perspective. And that was part of our judgment when we said yes to that medicine. So for every medicine we look at, we get clinical experts' views. So that's not been reported to us in another environment. However, if this is a real issue, I think it would be worthwhile investigating it. We need to see whether, in fact, there are issues for Scotland, because I wouldn't wish to see that happening, and SMC would wish to play its part in actually any solutions that were necessary.
Mr Powrie-Smith.
Perspective of the organisations that are investing in placing those trials, it is an issue. So we know that, and clinicians are stating it in open letters. We know if you want to run a trial, you need to be able to compare against standard care or the comparator, and to put those sort of some context around the numbers in Scotland, that it's, Mr Reedy will know from the life sciences, it's around 800 million to the Scottish economy and around 8,000 employees. Scotland has not only a rich history in terms of clinical trials, but also some opportunities in terms of informatics and so on for the future. And if we stifle our ability to grab that opportunity through not using some of the most innovative and new medicines, it would be a great shame.
And all?
Just following on from that, we also know that patients in areas where clinical research takes place, they do better irrespective of whether they're involved in clinical trials or not. So the benefits to the wider population are there also.
Yeah. This issue has been raised with myself by various representatives from the pharmaceutical industry. Also, one of the questions that was, or the concerns raised with me, was that if a new drug is not approved by the SMC, well, that's one issue. But in terms of when that company is then looking for a successor drug to that 5, 6, however many years down the line, that the clinical trials then will be compared against the drug that was not approved in Scotland with the new drug coming to market, and that then may make how the SMC does its approval process more difficult for the new drug coming to market. Hopefully I'm clarifying this correctly. Could there be a challenge that if we don't approve a new drug now for cost-effective reasons, but then a pharmaceutical company then does another drug which has added benefit, but their clinical trials are based on the drug that we initially didn't approve, that would undermine the ability to have that drug approved at a later date? This makes sense to me, Professor Timoney. I'm hoping you're following this.
Closely. Yes. Dr Fox. No, seriously.
I was just nodding along.
Oh, you're nodding.
I think you're making a good point.
Not nodding off. Okay.
No, I absolutely got your point. I think you're making a good point. But I think going back to what Professor Timoney said, we have the industry view on that. Perhaps we need to do a wider piece of scoping work to understand how much of an issue that might be.
As a Vice Council, I don't know how much progress we can make here based on, in terms of, it might be certainly something that we can consider for our future work programme, Jim. Sure. I think you know,
Can I pray your indulgence,
take this
Convener, and just
further.
ask if we could have on the record a response from perhaps Dr MacDonald and Professor Webb to the point that I raised in relation to clinical
absolutely.
research?
Yeah, but in terms of whether we can go further on the issue, I think it is a very important issue. It needs to be addressed. And certainly, if you know, we have a decision to make as a committee about whether we take any of this forward, then that would possibly be an area that we would consider hearing some evidence on. I mean, the other one was the individual patient treatment request that we need to get on here. We've had various pieces of evidence about clinicians not participating in the process. It's not worth all the bureaucracy, all the hassle, and the outcomes are uncertain and sometimes can raise patient expectation when, you know, when that would not necessarily be the good thing. So there are issues about barriers there that we've heard in evidence, and I think that was the point that Jim was clarifying earlier. We're not necessarily, you know, speaking on our own behalf here, but we're trying to reflect some of the evidence that we got. And there was also, in some of the evidence, the transparency of the process. You know, and so, speaking to someone who had a constituent went through that process, it is not a nice process for any individual and their family to go through. You know, it's not nice. And this the other when we're dealing with rare conditions, is that those individuals face the same problem as we face collectively. That catch-22, having some sort of clinical expertise in and around that, and around that condition as well, is another one. Does anybody wish to make any response or comment on the individual patient treatment request process? And
I'll start with, let's just be clear, medicines that go through the individual patient treatment request are those which have been determined by SMC to be not cost effective, and so therefore they shouldn't be generally used. But there has to be a system. SMC can't necessarily make a recommendation for all 5 million people in Scotland. We haven't seen those patients. So there has to be a way in which if a clinician has identified that there may be particular circumstances for that patient that they might benefit in a way that we wouldn't normally expect, or that we wouldn't have expected in terms of the SMC general advice, there's a system and process within a board where they could access that medicine. So that was the purpose of IPTRs. Effectively, there are two ways to get a not recommended from SMC. Either not recommended because we've assessed it and determined it to be not cost effective, or we have actually not assessed the medicine because the company have not submitted to us, and we will then say not recommended by reason of non-submission. I've been to all of the ADTCs across Scotland over the past year, and what they've said to me is one of the biggest challenges for them is having an IPTR for a medicine that SMC have not assessed, because the company have not submitted. So I think some work needs to be done to encourage companies to submit when it's a new active substance, so that the boards have that guidance from SMC when they have to undertake an IPTR.
Yeah. And again, it's affected sometimes by this cross-border postcode thing, although the SMC haven't endorsed it. They're making that request on the basis that if they were living somewhere else in the United Kingdom, they would be able to access it. So it further complicates it, I know. Sandra Auld.
From an ABPI perspective, I think there are a number of issues around IPTRs. We would suggest that if the SMC framework was broader based, then some of the IPTR requests would not come forward, and it isn't just in the rarer diseases. There are also issues around, for example, CNS medicines. So whilst I think it's the cancer medicines that are highest profile, IPTRs isn't just in that therapy area. So to reiterate, we would absolutely support looking at a broader base. With
a further explanation about a broader base and why that would make it.
Looking at the impacts on society, for example, for some of these medicines, not just the QALY based assessment system that's in place just now. Again, you know, SMC does a superb job within the framework that it works within. But it is, some of these medicines are never going to get through SMC, which is why a number of companies choose not to submit. They don't go through the expense of putting that submission in place in the first place. So that's one issue, and so in some respect, we feel that we're almost answering the wrong question with IPTRs. The process certainly, it's clear, doesn't work the way it was set up to, I think, or the expectation was, but it is answering the wrong question in some respect.
Just to come back on a few of those points. I think looking at the SPICE report to the Health and Sport Committee, around about 60-65% of IPTRs get an acceptance. I find reassurance in that. I find reassurance in that because that shows me that clinicians are able to identify the people that they feel they can make a case successfully for. But it also shows me that they're not afraid to put in where they think they've got a case, and some peer review around that may demonstrate that they might not have a case. So I think, you know, if it was 100%, I think I'd have concerns. If it was 20%, I'd have concerns. There's no right or wrong level, but I think I do gain some assurance about that. I think interestingly about oncology, there was a board review earlier on in the year, and it was significantly higher than that level, significantly higher, and I think that's important. As far as the broader base, two final comments. Broader base, I think I would absolutely welcome a discussion about drug versus non-drug interventions. We build a wall around our drug budgets, and nothing can get out of that, and nothing gets in. And that's not right. It's the second most expensive item that we spend in the board after staff. And that's the reason it's got lots of management around it, but that's the only reason we should be asking questions about how we use that spend. The questions we should be looking at are, do the people of Scotland want a fourth-line oncology treatment or a guarantee about their palliative care? Yeah. Now, we want both, obviously, but we may not be able to have both. Some of the questions about the integration of health and social care will come around whether we should be investing in that new drug on the horizon for dementia, or whether we should be putting our money into social care to support those patients. Those questions will be real, and we need to engage in that discussion. So I think all of the discussions about the broader base for the QALY should very much be taken into a bigger discussion about how we spend our money in support of health and social care. And the last thing is about the choosing not to submit. I find it disturbing that industry chooses not to play ball, because it does cause us problems. Now, I understand from what you're saying that you have reasons for industry not submitting certain things for SMC, but I don't find that a particularly helpful or mature response in terms of healthcare in Scotland. We should be encouraging all of those drugs to go through the submission process and the assessment process, because that aids transparency.
Richard Simpson.
I hear the figure of 65%, and that is, of course, the defence of the new IPTR system, which we must remember was a modification of the previous exceptional needs system and was designed under the new system to be much more consistent and read across. I'm not convinced that we've got that read across yet. And there is a lot of anecdotal evidence out there that clinicians are not submitting, either because they're feeling pressure from the board or for other reasons. And that is coming through to us very strongly. Indeed, I'm really quite concerned because I was in discussions with at least one pharmaceutical company in the last few weeks, and they had two clinicians who were going to speak to me and were then gagged by their health board. Now, I would like the health boards present to tell me that that's something that they would deplore, and that, in fact, that they would let to go on the record that any clinician out there who has any concerns about this system should be able to talk to members of this committee about their concerns, because we can't get to the bottom of this anecdotal thing unless, you know, we can actually get hard cases that tell us that people have either had pressure applied to them not to apply, or they have concerns about the bureaucracy, or they have concerns about meeting the exceptionality conditions under the IPTR. You know, if we can't have discussions on that, it's a real problem. So,
I mean, just in response, I would say, if that's the case, there's a mismatch between what we're trying to achieve and the reality on the ground. And I'd be disturbed by that, and I would welcome openness and discussion about that. My view is, and I've in the past been a coordinator of pre-IPTRs and have been involved in the development of some of the advice around the IPTR process. My view has always been, we are working as a board with the clinician to overturn the bit of advice that says we don't use that drug. If we can do that legitimately, if we can do that in a way which we can then say is reasonable to the rest of the patients that we look after and the rest of the population, then great. But if we can't, we shouldn't be saying yes. And so I think it's presented often as the board is trying to stop you using a particular treatment. I've always seen it the other way. I've always seen it, we will push this and try to get the use of this for the individual patient as much as we can, but it has to stack up. It has to stack up in terms of the criteria within the IPTR process, and it has to stack up in terms of getting broadly towards that level of acceptance in terms of cost effectiveness. And that's not about calculating some individual quality, but it is saying there are factors here that do send it in that direction. It's about saying that we can accountably say that, and reasonably say that this is an acceptable use of that treatment, and that it is different to the group that we've said no to. So I would say yes. I mean, I would support what you're saying. What you've said surprises me. I hope to goodness it's not my board, but
they wouldn't even tell me that.
But yeah, and I would also, on a broader issue, I would also hope that those clinicians would have the confidence and the access to discuss that locally. Very much.
I've got, we'll take the other help. I'll take the helpful advice from Jim Eadie and take the other health board before I go to Dr. MacDonald, and then I think I had Sandra Auld.
Yeah, I mean, I absolutely agree that we're really wanting open and transparency. I'm very disappointed if these are clinicians that are within my board, because they haven't made themselves known to me that I could help with that discussion. I certainly feel that the clinicians have got quite a lot of use of the forms now. They've got used to what they're needing to do, what evidence they need to submit, and it is very much on an individual patient basis. And I think the clinicians do, they understand what it is they're meant to be doing. And I would hope that they don't feel that that puts them off, because it's all based on their individual patient and their sense that this drug will benefit their patient in that particular clinical condition.
Dr. MacDonald, followed by Sandra Auld.
Industry certainly know that the IPTR is not just a way of turning a negative into a positive for all patients, but my understanding is that there is a lack of clarity in general on how the processes work, and that many of the physicians, as has been stated, find it difficult to know how to work it and therefore see the hurdles as not worth crossing. So maybe there's an education there. I think there's also a lack of clarity in terms of what the exact process is and exactly what evidence has to be provided. And again, I think there are differences across the health boards. So the lack of consistency and the lack of transparency, I think, is difficult for all parties if you look across the 14 health boards. I think also on the industry side, industry, coming back to the disappointment somebody mentioned, industry clearly want to work in partnership. But I think while it's not transparent and the hurdles are not clear and the consistency isn't clear, it's difficult for industry to work in partnership and say this is what we should be contributing. So I think all of it needs to be fixed before it fully works for any party.
Sandra Auld.
I would concur with a lot of what Francis has said. We, ABPI, carried out a survey of oncologists around the IPTR process and also convened a short life working group to try and establish, we thought there was an issue, but to try and establish if others thought that there was an issue with the IPTR process. So on that short life working group, there was industry, there there were clinicians, there were patient representatives and pharmacists. And the conclusion of that group was, yes, that there were some issues, and some of those issues were around the criteria for submission of IPTRs. But also, as far as the oncologist survey was concerned, we did get the similar comments to that which Richard referred to, that some clinicians were saying that they found the process very frustrating, they found it difficult, time-consuming, so they didn't resubmit. One oncologist said, my experience was purely negative. I stopped putting them in a long time ago as they were always rejected. It's hugely frustrating for patients and clinicians. Those were some of the comments that were fed back to us.
Yes, Chair.
Of the health boards, 65% was the figure that you quote in terms of the number of submissions that were approved under the IPTR process. I noticed that the number of applications being made has declined, so that in 2012-13 we're down to 135 applications compared to 2011-12 where we had 359 applications. Do you have any insight into why there is this decline, and do you recognise some of the comments that have been made about perhaps clinicians not having confidence in the system, or perhaps just not understanding how best to utilise the opportunity that is there to make an application?
Okay, if we take the first one, 12-13, we're obviously only 6 months in, so the data will be incomplete for this year, and that will explain a large amount of the difference. I find the data to compare between the boards is very difficult to interpret. For every one IPTR, we have 4 or 5 individual requests for unlicensed and off-label treatment that we deal with locally. And the slightly more complicated issue with that is that if you are a teaching board, some of the ways in which your clinicians will use those unlicensed and off-label requests will actually be, they're more likely perhaps to go down that route than they are to use an SMC no, because they're at the leading edge of what they're trying to do around practice. In terms of communication, I mean, we can always do better. There's no question. We've done training locally, and we've certainly switched our IPTR process into the service rather than board level, which it used to be. And I think we're always looking to improve that. I don't feel, my feeling locally is that we don't have people disengaged, that people are engaged right from the top. So our clinical lead, certainly within the acute sector, chairs a lot of these panels. But I think the ABPI have got these views, and those views have to be valid. You know, you can't just put them to one side. So there is something about exploring whether that is representative not just of oncologists or haematologists. I'm not quite sure which group you were talking about. And if so, making sure that we communicate those processes better locally. The thing that doesn't, the difficulty in stacking it up is the review around IPTRs for oncology showed a 90+ approval rate for oncology treatments. That doesn't quite stack up with the response that ABPI has got of a lack of confidence in the system. If it is a lack of confidence, then we really do have to do something about it, because those drugs are obviously getting approved through that process. So I think we need to look at it a bit further.
Anyone else? Melinda Cuthbert.
I mean, I fully endorse what David's just said. I mean, from an NHS Lothian perspective, with the CEL 17-2010 and the good guidance that came after that, we implemented it. We took the time, we engaged with the clinicians, both in primary care and secondary care, to ensure that what we finally put in place was acceptable and met requirements. I'm sure, as David's already indicated, that sometimes trying to get that message down to each individual clinician sometimes is difficulty. We went the route of using the clinical management teams, as well as that we also have clinical pharmacists associated with all of the specialities, and also there are primary care pharmacists out there in community which are associated to the GP surgeries. So there is advice, and they are actually encouraged to go to them, and they know on a day-to-day routine basis that they would go to them for advice on medicines. So that network is there, and there's been often times they'll call up the medicines management team or myself also asking questions about how do we actually submit, how do you do the forms. And I would like to think that we are open and encouraging and are helpful, and when in those circumstances where they think it is appropriate, that their patient actually meets the criteria to submit an IPTR as per CEL 17/2010 and the good guidance, that they are doing that. And if they aren't, then I would like to know why, so that we can try to address that locally within the health boards.
Sandra Auld.
Again, I would ask the question of the committee, in that, do we feel that in Scotland we need 14 different IPTR processes? From a patient perspective, this is an absolute maze. There's huge disparity amongst health boards in both their decisions, their decision-making processes. And when we were doing our research for this in one of the boards in Scotland, one of the criteria for consideration for an IPTR was that where there was significant media and political pressure, that was on a health board website. So for me, that's an illustration of the differences, and I'm not sure that that's what we would want decisions to be being made on.
Professor Timoney.
I think, therefore, in terms of trying to move this forward, one of the things perhaps we could suggest is that we should have a common IPTR form to be used in all of the health boards. I don't think we should have one system, because I don't think that's a good thing. I don't think it should be a central committee, because this is about timeliness and it's about local circumstances. But I think we could ask the boards to have one form so that everybody has to submit for the same form and the same similarities in process, and that should help address that issue if there is a problem.
David Plyflinger wanting in here, and a number of others would.
The reason I look slightly uncomfortable with that, we're just trying to make our form electronic, so I'm just thinking of all the things we'd have to unpick. But just to come back, I think to say the decisions are different, we can't say that. We can't say that. These are individual patient treatment requests. We can't analyse it at that level. I would come back around the national forum. To be honest, by all means. But the reality is, what do you lose in reactiveness, responsiveness? Some of these decisions have to be taken very, very quickly. And also, I can't speak for other boards, but our board has certainly tried to take this right the way down as close to the clinician responsible level as possible. That keeps it responsive, keeps clinicians engaged, and allows them to be confident in that process, hopefully, given the comments you made earlier. So I would say we have the guidance, and that guidance should lead to consistency of process. If it isn't, it's that bit that needs fixing. It's not new guidance or new systems, it's ensuring that we have that consistency and compliance. And I would also add again, keep coming back to the issue of communication. Things that do confuse are, access to drugs through trials, access to drugs for unlicensed or off-label use, access to drugs through IPTR, and the confusion that gets it, because that's not what the patient wants to know. The patient wants to know whether they can get that drug. Yeah, they're not so much interested in the route. They just want to know whether they can get that drug. So some of it becomes is a lack of understanding, and that's completely acceptable, around the route that has been given to access that particular treatment, and then the comparisons that take place from that.
Melinda, Cuthbert, and I'm going to try and bring this there.
Further to Angela's comment, just to let the committee know that NHS Lothian and NHS Greater Glasgow and Clyde are actually using the same application form. already, and also with regard to the evidence briefing templates that are used, the West of Scotland and NHS Lothian are also using the same. So we're we're aware of that, and we're speaking to other people within our networks to actually do that.
Dr. Green.
Thanks, Melinda. You got in there before me. Just in terms of managing to have some consistency with the process, in terms of cancer drugs, quite often there will be a regional association of health boards, and so that decision is made by one IPTR panel for a variety of boards, so that in fact there is a relative consistency. It may not be entirely an entire Scottish consistency, but there are, say, in the West of Scotland, 50% of all cancer drugs will go through the one IPTR panel.
So the cancer networks are the basis for it rather than individual boards, is that what you're saying?
Well, there's an agreement with the individual boards so that one board
leads.
Yes.
Sorry, just as a point of clarification, that applies in the West. That doesn't apply in the north of Scotland.
So, Powrie Smith.
Just to be clear as well, we weren't suggesting one single process for the whole of Scotland. We were hoping for the same process applied in 14 places, and those two things are slightly different. My former role as a director of a patients' organisation, there would be no way to make patients understand why there were 14 ways of doing something. Simplicity at the time that you need to go through an IPTR is crucially important. So I think it's about, as Angela said, maybe consistency of forms, so on, and applying the same process in 14 ways, you know, or in 14 locations, but in the same way is what we're aiming for in terms of consistency.
And I think even just round the table, I don't think we're looking for a solution here, but I think what we're doing as a committee, identifying some areas that may require some further inquiry on our behalf. Nanette Millen.
Could I just, it's not exactly related, but can I ask any comments around the table about the Cancer Drugs Fund that's available in England for patients, but that we don't actually have in Scotland?
No one? I'm going to wait them out, Jim, so I'll let you in. But Professor Webb.
I thought I would respond just to say that what the Cancer Drug Fund represents was a stopgap for the English government before they moved to value-based pricing. What that's going to look like, we don't know.
Sir Powrie Smith.
I would agree with Professor Webb. We don't know what the value-based price. I think what the Cancer Drugs Fund does probably demonstrate is you dedicate funds to access to medicines, and that can have implications and get those medicines pushed through the system so that funding can work. Rather than support of a particular type of kind of mechanism to drive access, I think what's important is that there are drivers in place to ensure not only that that patients receive those medicines, but that then is well thought through. I don't think it necessarily needs to relate to a particular disease area, but it's clear that it has an impact on the service.
Anyone else? Professor Timoney.
The Cancer Drugs Fund in England basically enables patients to get access to medicines even where NICE have said they're not cost effective. The result of that might be that the industry are less inclined to make their products cost effective, not just for England, but also for Scotland.
Okay.
Very brief on the Cancer Drugs Fund.
Oh, sure.
Convener. Yeah. No, it just, I kind of like the witnesses' thoughts on that overall spend in terms of cancer, that I think we're talking about the overall spend in treatment is not just medicines, but it's wider. So, for example, the Scottish Government's got a £30 million Detect Cancer Early Fund and a £22 million equipment invested in radiotherapy. So money could be spent on that, or alternatively it could be spent on a cancer drugs fund. Also, what would you say to, say, individuals who are calling for a special drugs fund for, say, Alzheimer's or heart disease? How would you create equity into the system? So it's just to get on record, because Nanette quite rightly has suggested a cancer drugs fund, but there was a political majority against it in this Parliament when when we debated it, a substantial majority, and I think it's important maybe to get on the record whether or not you support a cancer drugs fund or, like the majority in this Parliament, you're against it for the reasons I've given.
I entirely agree with what Bob Doris has been saying, and I think the corollary to that is we've got to get IPTR right, and we've got to get confidence in the public that it's right. So I think some of the suggestions about read across in terms of application are interesting. I also think there has to be some central monitoring of what's going on. I think there also has to be some assessment of the clinician's confidence in the system as well as the patient's confidence in the system. So there's a job of work that we shall have to discuss as a committee to take forward to make this the alternative to a cancer drug fund that is more equitable.
Did you want back in, Jim? No,
on the record, the concerns of the cancer clinicians that I put on record earlier, it would have been helpful to have a response from Dr. MacDonald and Professor Webb, just for completeness, in terms of a response to that.
The question, which comment it was?
Well, yeah, it's a round table. You're not compelled to respond to any question, and
Given the expertise that we have available, I think it would be helpful, but it's entirely at the discretion, of course, of the panel members. The question was about concerns that have been put into the public domain by leading cancer clinicians about the impact of what they perceive to be a lack of availability of innovative treatments and the knock-on effect that may have on clinical research in Scotland, and the very good reputation that Scotland has for clinical research.
Did your view differ from Mr. Powrie-Smith's? Can you recall?
No, I fundamentally agree with points made that it does need to be monitored, but it is certainly a foreseeable conclusion if the leading products are not picked up and become standard of care. You cannot put a trial in a country that doesn't have standard of care. I think it needs to be monitored to see if it happens. It may not be noticeable at the point of SMC approval because it's just a brand new drug, but it has to be monitored thereafter because it's thereafter that it will either become or not become standard of care. And certainly if it's not, the trials won't be there.
Anyone else? I'm reluctant to open this up again, but Professor...
No, I'm not going to open this up again. I mean, I think we would obviously be very concerned if we were not internationally competitive in our cancer research, as we are in so many areas. And I think Professor Timoney had suggested that we needed a scoping exercise to define exactly what the problem is. And I think, first of all, let's see what the problem is, because we have one view on that, but we don't have...
I think that's where we are. I mean, for the purposes of the committee, I think the question was very helpful from Jim, and it is indeed on the record, and we will certainly, it will be part of our considerations in terms of our work programme and what we eventually do through this.
Well, Professor Timoney's earlier helpful suggestion, I was just wanting to hear some other views around the table.
Yeah, must let us get on. You must let us get on, Jim. I know this is your last meeting and you're getting your last words, but so we need to push on. And I just, we greatly appreciate the people who are round the table giving us public evidence here today. But of course, we have engaged with them as a committee over some weeks and months, individually and collectively with the committee at other sessions to try and get a better understanding of this confusing and complex world that you live in and the job that you do. And it is, and we absolutely have at least some understanding about how complex this is. But from our perspective as well, we have spoken to patients' groups and we have heard them and they've communicated with us, and we felt it was very important to try and get some of that charged situation on their behalf over this morning. We may not have covered everything that you would have wished us to cover today. There may be issues that you feel that weren't raised that you might want to raise briefly with us here. But if not at this moment, then we would be happy to hear your views of this session, issues that may have been missed, in good time before our final deliberations of the work programme a week or so from now. Does anyone wish to raise any issues that you feel that we should have covered this morning? Or no? Dr. MacDonald.
Just maybe to reiterate briefly, in the context of the UK and the PPRS, so the pricing regulation system and value-based pricing, we would just ask that the committee seriously does consider this issue of how do you value medicines and potentially other interventions, because this is a British issue as well as a Scottish issue and an English issue. And I think the discussion of what is value and how do you measure it, I think the committee, I'd ask, consider that point, because it has a wide context.
Are we all content at this point? Well, again, thank you very much for your attendance, your participation and making this an interesting session. Thank you. We now, as we previously agreed, go into private session to deal with the remainder of our business. We're suspending at this point while we clear the room. Thank